Good evening, everyone. My name is Preston Fontenot. I'm the North American Sales Manager for NuSmile. Thanks, everyone, for joining us this evening on a Wednesday night. Like I said, for this course is going to be a 2-hour-long webinar on mastering zirconia. It's going to be 90 minutes of a presentation and then 30 minutes of questioning at the end. And tonight we have Dr. David Evans, who is a board-certified pediatric dentist based out of Oklahoma, who has done thousands of zirconia crowns and is someone who I considered an expert in placing ZR crowns and really giving invaluable information on tips and tricks on the preparation in ZR, and all around just very, very knowledgeable when it comes to placing ZR crowns. So it's a good speaker this evening. I'm excited about it. For your CE, this afternoon, once we complete the webinar, it'll be about Friday, 24 hours after we complete this course. You will see an email from our global events coordinator, Zoe Catchintones, with the feedback form. Once you complete that feedback form, then she will send you your CE. So if you have any questions over that, you can reach out to myself or to Zoe. But like I said, expect 24 hours on Friday. You should see that email come from her, okay? For questions, like this afternoon, we're going to go through the whole 90-minute presentation, and then right at 7:30, we'll stop the presentation. If we stop a few minutes early, that's okay. But the last 30 minutes, if you can use your chat, you can send in your questions that you may have. And then Dr. Evans will answer as many questions as he possibly can within that 30-minute time period. Well, with that, like I said, we want to get started. So I'm going to hand it over to Dr. David Evans. Thank you, Dr. Evans.
Preston, thank you. Audio good? Thumbs up?
Audio is good.
Okay. Well, good evening, everybody. Good afternoon. I know y'all are in different areas of the country, but it's good to be with y'all. Some of you are probably still finishing up some patients. Some of you are doing some charts. Some of you are probably residents. Some of you listening in a car all across the board. I appreciate and respect all of that. Some of you are probably home with your little ones starting to wrestle them and get some dinner made. So I appreciate all those different things. Being called an expert, I'm not sure if that's a good thing or a bad thing anymore, but I do feel like I've learned a lot of different things. So I'm excited about the cases that go well, and I try to learn from the ones that don't go well. But it's always a lifelong student of being a pediatric dentist. So I'm grateful to be here. I'm grateful to be with y'all. I've done a lot of these courses over the years. Webinars are not my favorite. I know they're incredibly convenient to be an attendee. That's how I get some of my CE as well. But I wish I could be with y'all in person in a nice hotel somewhere in a cool city. Having a nice breakfast, lunch, or dinner. But here we are, and we'll make it efficient, get some things done, hopefully learn some stuff. And I'd be happy to take some questions and mostly just share with you kind of my approach to zirconia crowns. I think one of the challenges of doing a webinar and using the term mastering zirconia crowns is we're all kind of at different levels. We have everyone from residents who just started residency a couple months ago to seasoned clinicians who just haven't quite jumped into zirconia yet. And then a lot of you probably have done a whole lot of them and you're maybe a little frustrated with them or want to get some better results. So I'll just try and cover the best that I can and reach as many as I can. Obviously can't see body language and figure out where I'm losing people, but I'll do the best I can to share stuff with you. Typically I pace the room. If you've ever been to a course that I've done for NuSmile or otherwise, I typically walk around the room nonstop for a few hours and use my hands a lot, but this time I get to stare at a screen. So hopefully you can all follow along. So zirconia crowns, we'll jump into it, and then you guys can ask some questions kind of at the end as we move along. So, let's see if I can get my advancer here. All right, so this is me, as Preston said, pediatric dentist, did the boards. Some of you just did those last week, 2 weeks ago. Hopefully you've regained your composure and have got your balance back, and hopefully you all survived. I'm sure you did great. The FAAPD, sometimes the young dentists ask what that is. It's just after you become a diplomat, if you decide you want to, do a little teaching and some community service and do an application and so forth, you can become an FAAPD, which is fellow in the American Academy of Pediatric Dental. But sometimes people wonder what that is because I know y'all are dentists as well. So nothing that exciting. My history, University of Utah undergrad, biology degree, University of Utah. Went out to dental school in Fort Lauderdale at Nova Southeastern University. Had a nice 4 years there. And I did my residency at Temple University Hospital in Philadelphia. So I had a great time there as well. And some of my favorite pastimes, and still enjoy going out to Philly. And then summer of 2012, ended up in Oklahoma City, bought a practice, had been around for 47 years. That was also the summer that zirconia crowns really kind of came into full fruition. So NuSmile launched their line at the APD meeting in 2012 in San Diego. I graduated 2 months later and grabbed my first box of D through G zirconia crowns and decided I'd try and figure out how to use these things. So having spent time in residency with the chippings of the white facings, the leakage of the composite strip crowns, and trying to figure out where do we go from here on anterior aesthetic crowns for pediatrics. That's where we were, and I wanted to figure it out. So through a lot of trial and error, that's how I did it. So this is a little bit of introduction to me and my family. As I said, I'm in Oklahoma City. That's my daughter Everly. She just turned 12. This is my little man Evan. He is 3, and this is our little baby girl Elizabeth. So sweet little babies I get to go home to at night and remember that all of these stresses of the day that you all are just getting through right now, especially on a Wednesday, they do all come to pass, and there are always happy in other moments after you've dealt with difficult parents or staff and all that kind of stuff. I'm in the trenches with you. As you can see, I'm still in my office just doing this tonight. So that's my cruel little introduction. New Smile is giving me a little bit of money to do this for you all tonight. I assure you it's not that exciting. But just as a disclosure, they're paying me to talk to you all tonight. But I do this because I enjoy my colleagues and because I feel like I've got a ability to kind of share some ways to do a little bit of dentistry different than you may be used to, or at least introduce some of you to zirconia crowns in the first place. Anyhow, they didn't fly me in or do anything else for me tonight, just sitting in my own office doing this for you. So kind of throw this case out there to kind of start things off and get some dentistry going. We see this case, sometimes you might see this patient maybe as a lap exam, maybe they're difficult. All you can see, there's a whole bunch of stuff going on in the mouth, but you can't tell are there caries. You definitely don't have any x-rays. Maybe it's a combative patient, maybe some autism. And you look in there and say, man, I don't know what's going on, but there's just a lot of something happening in that mouth. So you finally get them asleep, or maybe you sedate them, or maybe you just use a safety immobilization, whatever your route is going to be. And you finally get in there and you start cleaning all this calculus off, and you see that it's all just a bunch of buildup. You get halfway through and you can see, man, these are actually beautiful teeth underneath here. They're actually just hidden under calculus and buildup. So in this case, it's not even restorative. It's just a cleaning. But sometimes we can't tell which one it is until we get in there and start doing that. You'll see on a lot of my cases too, I do use the isolite on pretty much everything we do, from sealants to fitting space maintainers in unilateral row to all of our full mouth surgery cases in the operating room or in the office. As far as a heads up on me, you'll see on my cases that I share with you, I do quite a bit of conscious sedation. We do a lot of deep sedation in office with IV sedation with nurse anesthetists, and then we also go to the operating room a couple of days a week. There are 5 pediatric dentists in our office. We all are in a group practice that share a lot of these different things. So sometimes someone else might have seen them for pre-op. But here's the post-op on this patient. So I didn't actually fix a single tooth. Well, I guess it's relative. I didn't restore a tooth. We did fix a lot of teeth, so hopefully we'll have healthier gingiva going forward. But here's kind of a little snapshot of some of the things we might discover sometimes. On a case like this, as you can see, I'll do some light disking between those teeth and hopefully slow down some buildup in the future. Maybe the saliva and water and really basic hygiene might help that patient out. So sometimes we don't restore teeth at all, but when we do need to restore it, and some of you are dealing with insurance companies regularly like I am, you're always trying to figure out what they want, your pre-op x-rays, your post-op x-rays, getting approvals and so forth. So as far as the AAPD guidelines and kind of the backstop, there's not a lot of written instruction out there, but these are some indications that you'll find out there that your colleagues, hopefully we back each other up on these kind of indications for restorations. So when do we crown a tooth? When do we go from SDF to maybe sealing something to doing a small filling to doing a full crown? So some of the guidelines are here. One of them is caries on multiple surfaces, incisal edge is involved. Is there cervical decalcification? Sometimes you got cervical decal wrapping all the way around these primary teeth. Is one of the battles that I have sometimes, at least where we are right now with some of our managed care in Oklahoma, is you have a 2-year-old that goes to the operating room. They've got rampant caries on D through G. And then you get in there and you've got cervical decal that wraps around the first primary molars, wraps all the way around there, and you already have anterior teeth that are exposed and broken down. What do you do? You got a patient that's compromised, whatever the scenario might be. You all know how complex these can be sometimes. So what do you do on that patient? Do you do a stainless steel crown on there? Do you just polish that? Do you put some SDF on it while you're already in the operating room? Do you, what do you do? What do you do with that case? So one of the guidelines does say if you're in that one of those scenarios, potentially you do have to actually do a crown on that too. Again, I'm not indicating any specific treatments, but these are just justifications and potential areas that you might do those things. And then if there's pulp therapy involved, we do need to seal that tooth off. Unfortunately, I have extracted a lot of distal occlusal and meso-occlusal composites that have pulpotomies underneath them. It is really hard to get a good sealant on a pulpotomy tooth or a pulpectomy tooth, but particularly pulpotomy where you have those strong posterior occlusal forces. Anterior, you can get away with it doing a pulpectomy or a small pulpotomy with a lingual composite to cover that up. But when you get in the posterior and you start having multi-surface lesions and you put composites on those, they do tend to have a very high risk of failure. And then maybe there's minor caries, but the oral hygiene is really, really poor. So in that case, what do you do? Is there justification for that? And then one of our favorites for all of us, which is moisture control, always dealing with that. Johnny can sit in the chair, and yes, he can take an injection, but can he actually sit still while you isolate the tooth, put a band around there, get your wedge in there, and get everything dried off, get your bond on there, and composite, and then cure it a couple different times. Or do it just look good from the top? So always moisture control is a constant challenge in a world of composite and eluting agents. Obviously, you get away with that a little bit more with amalgam and some of these RMGI cements. But moisture control, I think, is probably one of the highest reasons for failure is some kind of moisture control, be that saliva or water or blood, whatever it might be. Moisture control, I think, is probably responsible for a lot of pediatric dental failures on restoration. So always being mindful of that. Which a lot of times for us, that's the difference between, hey, can I do this with nitrous? Do I need some conscious, or do I need to go to sleep? If I'm going to do 8 teeth or 10 teeth or 12 teeth on a patient that I can keep awake and do that, but the dentistry is not going to be predictable, then that's not something that I'm always comfortable with. So I want to make sure I was able to do my best job for a patient and for the parent. And personally, for me too, if you want to take pride in your work, when your stuff fails, that should be something that we think about. So the types of crowns that are out there, there's several types of pediatric crowns, those that are bonded directly to the tooth, which is kind of what we're talking about right now, which would be your strip crowns. Probably the most commonly used, universally paid for by insurance, which is strip crowns, a giant composite on a tooth. So those are pretty popular. They're directly bonded to the tooth themselves into the dental tubules, typically using a bonding agent. So, and there's different ways you can prep that. But a strip crown, being mindful of bleeding and so forth, tends to be one of their bigger challenges. We'll talk about that a little more in just a moment. Another option is pedo jackets. Space Maintainer Laboratory makes those. Polycarbonate crowns, been around for quite a while. These ones are directly bonded to the tooth, typically using a bonding agent. Second type is ones that are placed to the tooth using a eluting agent. This is something that there's some kind of intermediary between the substrate and the crown that you're placing on there. The eluting cement, and these are your RMGIs, these are your Keytacs, your GIs, and so forth, resin cements, whatever it is you decide to use. These are your indirect placements, which are what we're talking about tonight, and what are most commonly used, I think, as far as long-term and most stable. Strip crowns, universally paid for, very commonly used, easy to place, the first time around, and then the kind of the indirect ones. So these are your stainless steel crowns, which I think we're all familiar with. Typically don't place those in the anterior. I know some folks still do. If that's working out for you and your patients are good with it, then that's your call. Open face crowns, which are kind of, and I always salute the dentists that do open face crowns, not because I think they're a great idea, but because they're really hard to do. You have to do a stainless steel crown first in the anterior region, and then you have to drill out the facing of the crown and put a composite in there to try and match the adjacent teeth as best as possible. Kind of keeping that metal exteriors you can see around the borders, you get that little metal crown. But these are all kind of bridges where we got to today. And then there's the pre-veneered crowns. I think most of you are quite familiar with those. Most residencies place those quite a bit. New Smile's brand of that is called Signature Crown, and I'll touch on that really briefly today. And there's the BioFlex crown, New Smile's new product. It's only a posterior restoration. That's one of them that is actually a composite, or excuse me, a resin crown in the posterior. And then what we're talking about today, which is our monolithic zirconia crowns. We say monolithic because it's one shade all the way through. We don't have the shading that you and I would probably want if we were having an anterior restoration, where you want a gingival shade that's maybe a little bit darker than the incisal and so forth. But these are monolithic zirconia crowns, which have become a really cool product, definitely in the anterior. And that's what we're here to talk about tonight for the most part. And we'll touch on posterior a little bit as well. So this is one of my own cases here on the bottom, where D through G are zirconia crowns. It is just a beautiful case, objectively, being able to have a product like that that you can offer to send out into the world and really be almost resilient to most issues. So stainless steel crowns, won't spend a whole lot of time on here. And obviously not to use too many synonyms, but that's one of them that a lot of times the parents, you'll tell them, hey, the kid needs crowns. We need to put a crown on his tooth because we have large caries and the filling won't work. And then they just say, oh, we don't want crowns. We came here for caps today. And so you remind them, okay, caps, crowns, use them as synonyms. Sometimes the parent will be looking right through you when you give them a treatment plan with crowns on there, because Dr. Johnson sent them over to your office to have caps done. So just always keeping that in mind. The language sometimes will be deferred to the same thing. Stainless steel crowns in the posterior are still one of my favorite restorations. I love those in the posterior. They're so strong, so predictable, so forgiving. They've been around for a long time. So stainless steel crowns in the posterior really are one of my favorite restorations to still do. Then I kind of work my way forward or from front to back. Like parents really want an aesthetic crown. In that smile line, I'll work with the upper D's first, and I'll go to lower D's, and then we'll do lower E's. And then if they really want it, we'll do the upper E's. So hopefully that kind of makes sense. You think of the smile line, upper E's are typically the last thing anybody sees in a smile, unless they're kind of upside down and backwards. So these are kind of how I walk through those. But I do really like stainless steel in the posterior. Zirconia crown is a beautiful aesthetic in the posterior, and then the Bioflex New Smiles new crown, which we won't spend much time on those things tonight other than this kind of quick intro. All right, so here's a case for you that came into the office. And if you look here, you'll see, let's see if I can use this pointer within a pointer. All right, this technology is amazing. So here's one that came into the office. Another office had done D, E, F, and G with stainless steel crowns. You can see we've got some posterior stainless steel crowns as well. And now you can see tooth C and tooth H just have rampant caries. You can see that we didn't learn much of a lesson on that first time around. You got facial caries on M and R. And this is one of those that the parents had just really kind of tormented themselves and really weren't happy with the fact that they had stainless steel crowns in front of their kid's smile. It's kind of a curse they felt like they were living with. Some parents really don't care. So in that case, obviously just leave it alone. But this kid, we needed to go ahead and fix other teeth anyways. And so I offered to switch those out for them. So as you can see here, here's kind of the midway point. Again, because I use the eye slide, I typically do the left side than the right side. This gave me an opportunity to kind of compare those two different restorations. Clearly a huge aesthetic option. Or aesthetic increase, but also really just a better restoration for plaque repellent and so forth. So this is kind of the midway point on that case. And again, I'm not recommending anybody goes and switches all the stainless steel crowns out, but this is a pretty cool service for a parent that's been haunted by the history of those other ones. So we've got that first picture, and then here's the bottom one. Went ahead and did C and H, so now that smile should be pretty strong going forward. Just composites on those lower canines, didn't need to do a full coverage. But here's a nice case to be able to do that service for the parents. Also give this kid a smile they can be proud of through second, third grade. All right, strip crowns. So we're going to talk on those really briefly, not a whole lot. Here's an example of a strip crown. As you can see, they look really good. The best thing about a strip crown, obviously, is shade matching, in my opinion. You can get them to match, whether they're a B1 or a bleach shade, or whether they're a C. You can usually match that shade pretty well by using a composite. Unfortunately, they do tend to have some leakage over time, and a lot of times they start to have that failure. Look really good the day you place them, maybe a couple weeks afterwards, but over time, between the margin being super gingival or leakage and just kind of the stresses of plastic flexing every time it gets a little bit warm, and then shrinking a little bit every time that it gets cold, it has a little bit of a stress all around that too. So they can be great, but unfortunately, they can also be a little bit of a challenge. Pre-veneered crowns. I'm only going to touch on this to introduce you to New Smiles line if you're not familiar with it. Here's a C through H, M through R pre-veneered crown. Actually looks pretty good. Edge-to-edge contact, I never loved that. But with the stainless steel crown and a white facing, a lot of times because of the thickness of the facial lingual dimension of these crowns, oftentimes you end up in a edge-to-edge if you're not careful and mindful of that. So try and be mindful of that. You really edge-to-edge is tricky because that's also right where that veneer and the metal come together. And so any flexing and occlusion right on that spot is prone to fracture. So just being mindful of those. Try and establish or reestablish the patient's overjet and overbite. Be mindful of that going into the case so that you don't increase those forces on the teeth. Here's a New Smiles crowns. Again, just a little introduction. They come in a light shade and an extra light shade, as you can see on the right side of the screen here. So if you've got kind of your average patient, which I think light shade pretty much all around is really the more appropriate. You'd more of an A1, and then sometimes parents have a really bright tooth on one of their children, and you know, extra light shade, you can order that one if needed to. But the aesthetics obviously better than stainless steel crown, been around for several years. Most people are comfortable with that. The chair time is a little bit shorter because you do have the ability to have a little contamination. You can prep a little bit on the lingual, a little bit more on the facial, and that's how you can establish that because of the thickness of the crown. So they are a little more forgiving. Chair side as well because of that. And then, of course, compared to a stainless steel crown, a little more circumferential reduction just on that facial. I think people's favorite part is probably this crimping, that you crimp the lingual of that for the snap fit, that little snap that we all like to fill on a stainless steel crown. And they can be autoclaved. The challenge of these, the reason that Zirconia kind of challenged them in the first place and why we needed a different option, mostly goes to this metal substructure because you do get that little chipping, you get the edging in there, a little bit bulky. Obviously, because they're opaque, you don't get any reflection of the light coming off of there or going through that. It just kind of goes and stops. And so a lot of the aesthetics are a little bit challenging because of that metal substructure. And then you have to hold them in place while the cement sets. Fortunately, with with that snap fit on the lingual, a lot of times you can snap that on there and then let it set up on its own. If you've got a patient that's moving all over the place, you have to kind of hold that while your cement sets up. You can't use a light cure cement on a stainless steel crown because, of course, you can't get the light to go through the tooth because of the opacity and because of the thickness of the metal. So you're at the mercy of a natural set. But anyhow, that's kind of the rundown on those. Again, I'm not going to spend a whole lot of time on these. This is a Dr. Lucero, Matthew Lucero, does some stuff for New Smile, T through H case. This is that overjet and overbite that I think is important if you want to be able to protect that. Try and reestablish wherever they were when they started, but particularly err on the side of giving them a little bit of an overjet so that you don't hit into that. So ideally, that's where they start and end. But if you have to, err on the side of just giving them a little bit more space. All right, zirconia crowns. Why you guys actually got on this call? So here's a case, D through G, zirconia crowns. Little introduction on these advantages. Of course, the aesthetics, I don't think we really have to convince anyone of those. They've been in adult dentistry for about 10 years longer than they ever were in pediatrics. So right now they've been in adult dentistry for over 20 years, which is great because they did a lot of trial runs for that and be able to get us some time on it. It is an alternative for nickel sensitivity. I don't see a whole lot of nickel sensitivity. Those of you who do a lot of stainless steel crowns, perhaps sometimes you might see a patient that comes in post-op and has some kind of reaction that you're not sure of. I can only think of twice that I've ever seen this. I don't know how many tens of thousands of stainless steel crowns I've placed. But when I saw this, it came in post-op where there was just kind of a little almost petechiae all the way around these stainless steel crowns that I'd placed in the posterior where it just wasn't healing. Usually after 7 to 10 days of even a full mouth deep surgery, the gums are tightened up. That pediatric gingiva has forgiven you and everything looks nice and clean again. But if after a week or so you still have some tissue that just isn't quite healing right, that's where I've noticed it before. So zirconia is an option for that if you need to pop that off and put it back on. Of course, we're not talking about the nickel sensitivity that someone might have from earrings or something basic like that. We're talking about a true allergy. I'm in this case. And then this is probably people's challenge, but it's also part of the option that you have to consider is with the tooth reduction. You have to take off a little bit more tooth structure because, of course, the thickness of the crown is about 1 millimeter all the way around. Versus a stainless steel crown, which is, sometimes people do those with the Hall crown where you don't even prep the tooth at all, you just snap it on there. And they can be autoclaved and reused if they don't fit right. Disadvantages, this is probably one of the things people really don't like about it is the no crimping part. You don't have the ability to get that snap fit on the lingual that people are used to with their stainless steel crown white facing. You do have to prepare the actual tooth to fit the crown instead of the crown to fit the tooth. So a lot of times you can just take that crown and snap it on there. In this case, if you push it on there hard and it snaps, then that snaps because you just broke the crown. So then you got to buy a new crown. So snapping is not good in zirconia crowns. Saliva and hemorrhage, I think this is the biggest challenge that people have. I think the least favorite thing people have is that they can't crimp the crown, but the saliva and hemorrhage has got to be controlled. And that's the same with your composites, like I mentioned a few minutes ago, but particularly with these zirconia crowns, where you have a eluting agent that's going to go all the way around the tooth, and that is the only retention that you have. So you got a pure chemical retention instead of a mechanical and a chemical. So you don't have that snap fit. You're purely dependent on your cementation, which means you've got to make sure that that cement is getting to those dental tubules. And we'll talk a little bit about that, of how it's kind of some options on how to do that, how to get ahead of that. Learning curve at the outset, which is why you're hanging out with me on a Wednesday night. And then that last part on there, sorry, I didn't see that last one, is the cost. Obviously significantly more expensive than stainless steel crown, really not a whole lot more than a white facing. So if you're already doing white facing crowns, the pre-veneered crowns, and that's really not a huge change to you cost wise. These do come in a light shade and an extra light shade. As I mentioned, light shade is pretty much where I hang out on almost everything that I do. Every once in a while, you'll have a really bright white front tooth, and you might want to go with a lighter shade, but that's pretty unusual, at least in my experience. This is the numbering system that New Smile uses. This is they use the Palmer notation. As you can see, we've got the upper right on this side. So you can see it's the A3R, which means the central incisor, size 3 on the right. And then that on the other side, we have that posterior. So you can see E4R, which is a second molar primary, which is E, and then 4, which is the size, and R, which is the right. So these are pretty small laser inscriptions. They're on the lingual with New Smiles. And so you do have to kind of look for them a little bit. They are something that you can polish off if you have a parent that you think that's going to bother. Most of the time, no one cares. And eventually, after toothbrushing and just normal wear, they do tend to wear off. You don't see them anymore, but this is the numbering system for your staff to get used to. And they come in a regular and a narrow. So this is New Smile's version of a space loss would be the narrow. So if you have someone that has space loss, mesial and distal from large caries, or you may have a little bit of drifting from the teeth, you can go ahead and use a narrow on those. And then there's the regular. People do like the narrows quite a bit, I think, because there's a little less buccolingual reduction. Even if you don't have space loss and you can use the narrow, you can just use the larger crown. You don't have to remove as much buccolingual because of that. You can see on here it has that capital N on the outside of that, which is the narrow part of there. So these are one of New Smile's kind of later additions after we had done zirconia for several years, but a lot of docs do really like the narrow crown. I think it's a little easier on the preparation. This is one of the things I mentioned briefly a moment ago, but something that's really important to keep in mind is the paradigm shift. You've got to keep in mind this is a new crown. So historically speaking, we would use the still crown, which you just modify the crown. You can crimp it, you can trim it, you can do a whole lot of things that you can, frankly, you can just push on there really hard and it'll just go right into place. You can do that with still crown, and you can crimp it and do that. But on a zirconia crown, whatever company you want to use, you have to make the preparation of the tooth fit the crown. So the crown is already established. You can't change that. And so you have to take the negative of the crown, and then you have to do that on your tooth. So you're making a substrate look like the crown, and then you're filling it in with eluting agent. So finding out where those little discrepancies are is how you have to prep that tooth, instead of the opposite, which is, hey, can I crimp this? Can I just push a little bit harder? Can I have the patient bite down? It'll just put it right into place. You can't do it on zirconia crown. You need to decide where it's going to go, and you have to make it go there on your accord. So here's the internal contours. These are the four major players in zirconia. New Smile is on the top left side there. So each one of them has a different way of kind of increasing retention value on the intaglial surface by hopefully increasing surface area. New Smile with that little stippled look, as you can see on all their walls and on the occlusal surface. They have that uniform thickness across the occlusal, which helps, I think, with some of that strength and the occlusal forces they're going to experience. But this is their way of increasing surface area by almost that sandblasted look, as you can see on there. And then here's their proximal view of the crowns. New Smile is on the far left side. I used to have the names of all the other companies on here, but just out of respect, I just don't really care to do that. So this on the far left side is New Smile's crown. Obviously, I'm a fan of their anatomy, a nice natural emergence profile from the gingiva. Some of the other ones are a little bit easier to place because they don't have that convergence, but unfortunately that can put a lot of pressure in the gingival sulcus. So I do like the shape of this one, but it does mean that you have to be a little more mindful of your preparation when you do that. Some of you are probably familiar with New Smile's Tri-End system. This is purely optional, so don't feel like it's something you have to do. Some people feel like they don't. That's a waste of time and an extra step. I can tell you, I don't know exactly how many of these I've done, over 10,000, 12,000 of these crowns, and I still use my Tri-End every time I do that. So the basic concept of the Tri-End crown is you're going to just take this pink crown, and it's going to do all of the dirty work. So it's the same size and shape of the one you're going to eventually cement on there permanently. So you take this crown and you go on your preparation, and you figure out where your interferences are. You prep the tooth. This is the one that's getting bloody. It's getting saliva. It might have some foodstuffs on there. All the contamination happens on this pink crown. After it goes in and it sits where you want it to, you take this dirty crown, you set it aside, take a brand new crown out of the box, and fill that one with cement. And then that one has never been contaminated, never been used before. So you're eliminating all those steps for contamination and potential failure for bonding interferences. And they take that pink crown, and your staff can go and autoclave it, they triturate it, or whatever they need to do, or ultrasonic it, and then autoclave it and clean it, and then you come back and reuse it again. So you can use these hundreds and hundreds of times, and these are the ones you want to break. These are the ones you want to have issues with. So you have a couple of sets of these pink ones if you want to. I found a much better success rate this way, and it actually makes me faster. I'm not slower. These extra steps are for the staff, not for you. So the goal of this, again, is I really want to avoid saliva and hemorrhage contamination, because I do find that is where most people's debonding happens and failure happens with these crowns, is when they don't have a clean substrate that they're bonding to, or because their crown is contaminated, it's going to fail at one of those two places, either the integrity of the crown or the surface of the substrate, which would be your pontic, or not your pontic, sorry, your substrate, your actual crown, the tooth that you prepared there. So eliminating extra steps, of course, is part of the goal, so you don't get things dirty, and then you can reuse them over and over again. It's just a little video that uses a nicer voice than what I just used, but that's the whole concept, is walking you through that. So we're going to go through a couple cases, and this is one that I did myself here. This is a conscious sedation case from a patient that I saw in a little charity clinic with the dental students here at the University of Oklahoma. And of course, this was outside of their purview, as most of you can imagine. But this is where the actual teeth came into the office. You can see they're pretty bad. Some of you are probably saying we should probably extract those 4 front teeth, and I don't disagree. If that's what you wanted to do, no problem. I wanted to try and save these teeth for this kid. So we went ahead and did those. We did the posterior in one visit, and we came back to the anterior in the next visit. Most of you who have done enough of these types of cases know, well, cases in general that are full mouth that are split into multiple visits, that you want to do the posterior first. One, they need them longer and a little more function. But also, if you do the anterior first, they don't come back for the posterior. So anyhow, we did the posterior, came back to the anterior. This is D through G, as you can see here. This is immediate post-op, and then here's 15 minutes later when we were getting ready to dismiss, as this patient was already ready to go. And you can see the tissue. These are mom's fingers and hands kind of retracting that lip for me, because I was just amazed based on that pre-op. As you can see how bad these gums were, how inflamed you would expect them to be, how quickly the body was receiving and happy with the zirconia crown. You can see that gingival tissue just calmed right down and laid back down on the tooth. So a beautiful case as far as the materials go themselves. Here's another one that some of you might see and say, man, look at these, the gingiva is really swollen. You can see paragingival caries, subgingival caries. By the time I prep these teeth, it's just going to be a mess. It's going to be bloody. The tissues are going to be really irritated. And certainly that would be the case and can be the case. But can we do that? Can we get these to heal up? And here's an immediate post-op on that one, where you can see the tissues are actually already doing okay, and they're laying down pretty nicely. This is a C through H case on the upper anterior. So same kind of thing. And if you wanted to, in this case, these tissues will heal. They'll collapse pretty nicely. They're tightened back up very nicely into their rest position. But if you really wanted to, you can see on E and F where we started off with severe caries between those, and likely going to have that papillae kind of a little bit inflamed. If you really wanted to, you could take a suture and throw it through that papillae between E and F to the palate and pull that a little bit tighter if you really wanted to get the parents excited in post-op. But that one will heal up very nicely. So some of these cases, one of my favorite things about zirconia crowns, and particularly in the anterior, is the ability to match natural things. Matching a natural single tooth restoration or a two-tooth restoration in the anterior with a white-facing crown can be very challenging because they're bulky, because of the light reflectivity I already talked about, really the aesthetics, the shade matching, and so forth. But on these anterior teeth with zirconia, if you can kind of rob Peter and pay Paul and do some kind of adjustments and manicures and things, a lot of times we can get a pretty cool result with that. So here's one immediately, again, kind of the same kind of scenario. If you can think of where these caries are, you're going to do that preparation. Here's our immediate preparation. You can see I did pulpectomies on these teeth, and I'm giving you a little bit of an occlusal view on there, an incisal view. So you can see that. This is the pulp therapy with local anesthetic injected around those tissues, trying to make sure we don't have any excess bleeding. We've done our trying crown, and here's where we are getting ready to cement those. And then this is the centrals only. So again, when you do E and F by themselves, it can be hard to just do E and F. One of the things that's critical with doing E and F by themselves, definitely with just doing one of those centrals by themselves, is sizing your crowns beforehand. Probably one of the biggest piece of advice that I try and give our young docs or anyone that ever is trying to figure out how do I get to kind of another level of aesthetic restorations in the anterior is sizing. You've got to get the sizing right. The two things that the aesthetics will get thrown off by is one is the size, and the second one is the rotation. You've got to make sure that you're in the arch form and just hit where that light's going to reflect, where it's going to bounce back at mom. What's the rotation? Am I truly in the arch form? Usually that requires taking your mirror and kind of backing it off a few inches so you can get a full arch view. You'll just see a slight rotation. And maybe you're looking at it from the facial and you think, man, something just looks a little bit off. And then if you pull back, you'll see, aha, it's just a little bit of a mesial or a distal, proclination that's just not lining up just right. Rotate that back and you'll be good to go. So as far as size selection goes, ideally you really want to choose whatever they came in with. That's probably my biggest piece of advice on size selection is take that tri-in crown and you just pick it up and you go edge to edge. Take that and line it up directly with the tooth that you're replacing and just mesial distal, what is that dimension? Same with the anterior and the posterior. What did that patient come in with? My whole goal is always to do exactly what they came in with, the best I can. If they came in with a size 3, they're going to leave with a size 3. They came in with a size 7, hey, no problem. Give them a size 7. Don't grab your burr and turn it into a size 4. Give them whatever they came in with. And if you do that, it's really going to be helpful with growth and development, but it's really going to be helpful with your anterior, getting these things to look right. And if you can't decide, or if it ever feels like you're on the border of a 2 and a 3 or a 2 and a 1, always pick the size that's one size smaller in these anterior teeth. If you do that one size smaller, because of that little bit of bulkiness and because of the light reflectivity that you'll get and a little bit of that show through, if you choose one size smaller, if you are on the border, it's always going to look a little bit more natural. Of course, you tell the parents, if you create a little bit of spacing where there wasn't spacing before, just teach them about primate and leeway spacing. That's going to be helpful for those permanent teeth when they come through eventually. But really, it's also going to look a lot better And one of the other things that it does is it allows you the ability to do a little bit of manicuring. So if you do tooth E and tooth F and you use a little bit of a smaller crown, you can do a little bit of just a nice light-handed manicure of D and G. You can kind of change those line angles a little bit if you need to. You can shape those distal and incisal points, and you can make everything kind of look like the teeth that you just put in there. You can do some light manicuring on those teeth. But if you start with the biggest crown, and now you can't do anything with those laterals or the centrals if you're doing the other one, vice versa. So moving on to this one. This is a short little SDF/zirconia case. I don't do a ton of SDF. I will be the first to tell you I am a restorative pediatric dentist. I think I'm pretty well known as that in my community, that we really like doing rehab cases. I love taking a mouthful of bad teeth and making them functional again and healthy and hopefully even aesthetic when possible. But I really enjoy restorative dentistry. So I don't do a ton of SDF is my disclaimer in that whole little rambling I just did. But when I do SDF, my goal with that is to be able to either get the time that I need to be able to get these roots to form, to be able to get a patient into the operating room, or if I need to be able to do that, to just buy some time on a kid that's sick and maybe isn't allowed to do an anesthetic at this time, or maybe we're trying to get through some kind of a process on a cancer patient or whatever it might be. The whole goal for me is to be able to buy some time with SDF. So on these young patients, I really like to get those roots to at least form and get them to mature a little bit more. So this is an SDF case for me. I will be the first to tell you I don't floss SDF between posterior teeth. That's really just not my interest. And I have no issue with those of you who do and that think that's the right direction to be headed. That's great. No issues with that. Of course, we all find our success different ways. So here's my SDF case. You can see again showing that left and right. This patient, it's finally get them in the operating room. Again, those teeth, they come in, they're that broken down. As you can see, if SDF attached as well as it did on that far left slide, then obviously these teeth were really broken down, right? SDF attaches to areas where there's decalcification and breakdown, where those little proteins are able to attach to that. And so if you have a tooth that is fully black all the way around, most of you know that is a really rough tooth. So it started off in a bad spot. But in this case, we were able to kind of freeze it with SDF, which again is why I like SDF and how I like to use that, and be able to get them in the operating room and see if I can still save those teeth with a parent that wants to. And if there's a parent that doesn't want to, if they're just like, hey, I'd rather just take these teeth out, that's fine. I don't have an issue with that either. I don't mind extracting teeth, but I love saving teeth. I just really enjoy doing that. And you can see we even already had these notches starting on the lower anteriors as well. So we did zirconia on these lower two, and then we did D through G. So able to save those teeth and give this kid a smile, hopefully for 4, 5, 6 years, whatever we can get out of it, but not having to extract those. That's how I like to use SDF. Again, I know it can be used a lot of different ways. One of the questions that typically pops up on SDF, or people ask about SDF, is if we place those, do you have to take all the SDF out to do your zirconia crown? The answer is no. At least doctrine by Dave, as far as what happens with SDF. If I have a tooth like this that requires that much SDF to be able to freeze that tooth, which really is what I consider this, is buying myself some time, then typically by the time I even prep the tooth for a crown, most of that SDF is going to come off. Also, just in my brain or in my mind of the mechanics of dentinal tubular bonding, which is really what we're doing with eluting agent, is we're getting these little fingers to go inside of the dentinal tubules or the cemental tubules, wherever your prep is. Not here to judge, but anyways, wherever your preparation ends up, that cement is going to go into those tubules and create little tissue tags. That's what holds your crown on. And so if those tubules or if some of those attachment points are covered in SDF, then it could compromise your bond just a little bit. But anyhow, I don't really find a whole lot of SDF left by the time I do mine. You can see on these preparations here in the middle, as I showed you, there is still a little bit of SDF on the incisal edges, a little bit on this facial as well. I don't feel like I need to take that off. I always want to save as much tooth structure as I can. If I've got healthy, sound tooth structure, that is my best option to keep this tooth. So the less preparation, the better, of course, but I also need to be able to get a result that makes sense. So anterior crossbite, can we do anterior crossbite with zirconia crowns? The answer is yes. This is one of those cases that you just really need to make sure that you understand what the crossbite was. If the patient comes in with a 60% anterior crossbite, let them leave with a 60% anterior crossbite. Don't make it worse. Don't create a crossbite. Don't try to correct a crossbite. I know some people may have a different opinion about that, and they may want to try and do a solid and do some little, same day orthodontics and try and change a crossbite. I would really steer away from that with zirconia crowns. Maybe you can do that with some ramps and with composite and other things, but I would really be very cautious with zirconia crowns correcting a crossbite. Really just allow those teeth to stay in the position they came in with. If we start doing those things, we change the angulation of where the crown is versus where the root is. Sometimes the eruption path will change, and you can get yourself in a little bit of a tight spot. So crossbite, in my opinion, is not an extraction case. I know there's a lot of people that do have that opinion that anterior crossbite with severe caries, you'd probably just take those teeth out and move on. I don't have any issue with that. I salute you if that's what you want to do, and that would be the easier route a lot of the times. But I do think if you want to save those teeth and you have a parent that cares, then I think you can save those without worrying about that. Just make sure that you understand where you start. So if you start with a crossbite, end with a crossbite. If DNG are in crossbite and ENF aren't, just do them the same way. Just don't change what they came in with. The best thing you can do, whether it's a composite, a stainless steel crown, or a zirconia crown, or any other restoration, in my opinion, is to let the patient leave with whatever they came in with. Whatever they come in with, send them home with that. Don't try and change their bite. Don't try and change the size of their teeth or the size of their crowns. That's where you kind of get in trouble with eruption and with exfoliation and so forth. So probably the only caveat to that, or the exception that I would say that I have been a part of, is if they came in with like a size 1 central, is maybe I gave them a size 2 if they had giant spacing, if they just had that picket fence look all the way across the front. And that's one of mom's biggest concerns. Then instead of a size 1, maybe I give them a size 2, but I don't close that space. That'd be a bad idea. So. And then on these anterior crossbite cases, if you do feel like it's a deep, heavy bite and it's in heavy contact, then you can take a fine diamond and just reduce that cingulum just a little bit and reduce that contact point so that you can lighten that up a little bit and reduce some of those forces. Put a little fluoride varnish on there for good measure and to feel good about it. But this is just enameloplasty. It's done every day in orthodontics and makes people more beautiful. For some reason, I think in pediatrics, we're a little averse to doing some of these things. But enameloplasty in the anterior, like I mentioned a moment ago, to make teeth match each other, or in this case, to lighten up the contact on a crossbite to give a nice aesthetic result, I think is completely justifiable and should not compromise the tooth. So you shouldn't be getting deep enough to have those kind of issues. Lower incisors, these are MIDFL composites on lower incisors, or even white facing crowns on lower incisors is really tough. It's tough to do that and do it well. On zirconia crowns, I love them. They wrap the tooth up. You can just get a full seal all the way around, very strong, very natural, very aesthetic, of course. I do really like them on lower incisors. Excuse me. And I do them quite a bit. When we have more than 2 surfaces, I try to do a zirconia crown if possible. I'll do 2, I'll do 3. But on a 2 or 3-year-old that has more than 2 surfaces in a lower incisor, I really prefer to be able to do some kind of full coverage restoration. If I'm going to get that tooth to last to 6, 7 years old, upper anterior, once I get past 2 or 3 surfaces, really like to have a crown on that. Otherwise, I end up having to redo that dentistry. When all 4 or all 6 aren't needed, these are some of the cases that I really like zirconia for, because you can do some cool stuff. As you can see on this side, this is an exact kind of a great example of when you can do the zirconia crowns and then do a little bit of manicuring. So the right side of this patient are the zirconia crowns, the left side are natural teeth. Didn't need anything done to them, which sometimes we see on like really dominant-handed patients or dominant-handed breastfeeding mothers. If they feed one side all the time, sometimes one side of the mouth will have all the cavities and there's nothing on the other side. Similarly, a patient that carries their sippy cup in a specific spot or their bottle in a specific spot, sometimes you have that unilateral side that has a problem, the other side doesn't. So doing these with a white-facing crown would be kind of tricky, but doing the zirconia crown and then giving yourself a little bit of ability to shape those teeth is one of the reasons that I really like that opportunity. So this is kind of give you a comparison, because I know that zirconia has a bad reputation for being aggressive tooth restoration, and that we have to take off a lot of tooth structure, and that you're doing something immoral. As dentists, I think we're in general very conservative on how we do our dentistry, and we want to do what's best for the patient. We want to not do harm. We want to try and be as conservative and as non-invasive as possible. And so I think sometimes there's a level of guilt when we have to do a preparation. One of the things I would just remember for each of you is remember our general dentist colleagues or our prosthodontic colleagues that do full mouth rehabs all the time, that are doing PFMs, they're doing zirconia crowns. They're not apologetic because they have to take off more tooth structure to give you an aesthetic result. And for that reason, I think we should take that off of our guilt level and just go ahead and do the restoration that's needed. So if the restoration is 1 millimeter thick, well, you got to take off 1 millimeter tooth structure. And I don't think you should have to feel bad about that. So here's a kind of a comparison. So here's a stainless steel crown, size 5, that fits on the lower right. Here's a size 5 of the zirconia crown. You can see the difference in the preparation. So you can see it just doesn't quite go down over that. We've got a nice wall on that axial wall that's going to hold you up from doing that. This is a nice illustration of what the preparation difference would be. Obviously, we can do just a short feather edge all the way around on a stainless steel crown. Fairly break contacts is probably what most of you do if you're not doing a pulpotomy. But with the zirconia crown, you are going to have to take off more tooth structure. We want to be very specific of how we take off that tooth structure. So we want to do that uniformly. We want to do that around the tooth and in specific areas, not just mow down the whole tooth. That's where I think we get into some trouble. So that's the kind of the preparation difference. Here's some posterior crowns to share a couple of those for you. So here's 8 posterior zirconia crowns where we did all of those on this patient. This isn't where I would jump to from the beginning. Those of you who have done a lot of these before, obviously you can be comfortable doing this. If you are new to the game of zirconia crowns, and I want you to be mindful of this, don't go in and cut all 8 of these at one time. Go in and do 1 to 2 at a time. And I know that probably sounds crazy, but start on the left side, start on the right side, do tooth K, then do tooth L. Just always give yourself a frame of reference. So I think it's very important to always have a frame of reference, whether you're doing anterior or posterior, so that you're not creating new issues on your side when you cross a midline or you cross anterior to posterior. This is kind of this is a light posterior zirconia occlusion. As you can see here on the top right of this patient, between tooth B and tooth S, you can see that kind of light little space between those. And then we have full intercuspation between A and T on the right side. So this would be ideal if I could do that all the time. You can't always do that, and sometimes it's because of the actual condition of the tooth when you started. Maybe it's a severe caries, and so you're going to end in hypoocclusion regardless of the restoration that you use. But if I have to choose, I would rather have a light occlusion on zirconia to zirconia than I would go straight full intercuspation between the 2 of those teeth. And here's the other side of that same patient. You can see this would be ideal, that you can have a full intercuspation between all 4 of these molars, and there's no light or anything between those, but that's got to be right on because you are hard material on hard material. And you can see this is a full mouth case. So when I do a case like this, where I'm going to actually do the entire maxillary arch and zirconia crown, and then do the other 4 posteriors on this, I do them, 1 at a time as far as the preparation goes. When I mean 1 at a time is I'll go ahead and do like K and L together. I'll prep tooth number K using L as my reference, and then I'll try my crown in. Okay, K is done. Great. Now I prep tooth L and I put them in together, make sure that they fit right. And then I go ahead and do A and J, and then I can cement those together. And then I do the anterior. So I never cross anterior and posterior, meaning I always do the left side first, and then I do the right side. But when I'm on that left side, I do the posterior first, and then I'll either leave those in place with the stainless steel crown snapped in place, or zirconia crown, I'll cement those in place, and then I go on to the anterior. If I go in, I just take my biggest, baddest football burr, my donut burr, whatever your favorite coarse diamond burr is, and I just cut all these teeth down. And then I want to take zirconia crowns and just try and make them all mix and match. You're gonna be in over your head very quickly. So always give yourself a frame of reference. That's one of my key advice to you is on these posterior teeth. Please always know where the adjacent D or E is, and on the anterior, please always know what the contralateral side looks like. So give yourself a frame of reference on those. Here's the tissue attachment slide. It's probably one of in just a moment I'll show you a picture of it. But here's one of my main reasons I really like zirconia crowns is they tend to be very biocompatible. They kind of clean themselves almost, where they're so shiny and well polished that just your normal saliva and just eating and drinking tends to actually help them prevent a lot of buildup. So much more favorable for that. This slide is probably one of my favorite slides here on the bottom right here, and I wish this were my slide. It's not. This is a picture taken, and Dr. Kroll had donated this other one, but you can see on this is all 3 restorations. We have a composite on the lower right with this canine. We have a zirconia crown. We have stainless steel crown. And this is coming in out of the wild. So this tooth and this set of teeth are coming in without having a prophy or anything done yet. You can see we have the plaque buildup along the stainless steel crowns. Again, doing fine. They're protecting the tooth. If this is a composite MODO or MOD, you're probably in trouble here at some point. But you can see this gingival margin where you can see from the attached gingiva down this gingival margin how much of a space that is. Then look at the zirconia crown. Look at this nice stippled ring all the way around that. Very nice margin. And then this composite down here is doing fine enough as well. The gingiva looks pretty good. So just all by itself, without having any, at least seemingly any awesome hygiene, you can see how well that tissue is responding, and how well that zirconia is helping that stay clean. This is one of the common errors that I already mentioned earlier. We got to be careful how we size these crowns. In the posterior, your dimension is mesial distal. So whatever that mesial distal dimension is, Again, if they come in with a 5, they're a size 5. So before you cut the tooth, I know this is going to sound annoying to those of you who have done a whole lot of teeth because you're used to just cutting them all down and then snapping crowns on them. And I get that. I did it this morning. But with zirconia crowns, look at that tooth and say, okay, what is the mesial demescent? What's the mesial of the 6 to the distal of the D? How much space do I have? That's the size crown I really want to end with. And if I have to, I'm going to go a size smaller, but that's the size crown I really want to end with. Or you can say, okay, what's the distance between the distal of the E and the distal of the canine? I'm going to do K and L together. I'm going to do a D and an E together. That distance is what you have to decide which 2 crowns you want to put in that space. One of them might have space loss and be broken down. One of them might be a little bit more strong and not need a pulp therapy or having space loss and so forth. And then you can decide what sizes you're going to use. And then that's it. So you just decide these are a size 4, this is a size 5. Take those pink crowns, set them aside. Now start doing your preparation and trying those ones on. Don't go in and just prep it and then say, okay, is it a 5? Nope. Is it a 4? Nope. Is it a 3? Nope. Is it a 2? Yep, it's a 2. And so on those, if you do that from the beginning, you're going to save yourself a lot of headaches. You save your staff some trouble on having to turn those crowns over. And then most importantly, you get a beautiful result, being able to stay within that space. You're not going to cause any ectopic position of 6s coming in or get into the leeway space in the anterior or any primate space as well. So these same principles, I think, are very helpful all the way along if you'll just choose that size before you start. I know most of you are probably not loving that idea because you're really good at doing crowns, but if you do that in general, it's going to help you quite a bit. So.
Hey, Dr. Evans, real quick before you hop into the next slide, I know we had a few more people hop in on here in the last couple of minutes that have raised their hands for questions. We would love to answer them right now, but we are going to hold all questions to the end till right at 7:30. So if you can either write it down and then right at 7:30, we'll start to answer those questions. I don't want you to think that we're ignoring you whatsoever, but yeah, that's we will hold all questions from 7:30 to 8. So just giving you that heads up. Okay. Thanks, Dr. Evans.
Sorry, guys. I would love to be checking each one of you in this room right now if I could, but unfortunately with webinars, we've got to roll this way, but I'll be happy to address whatever it is you want to. And if I don't, then I can contact you later. So you're just going to go through some concepts, kind of some things that I've learned and some issues that I've had through time and give you some tips on common frustrations and things. So as I've now mentioned 3 times, use the try-in crown. And if you don't use the try-in crown, if you use a different company, again, I want to help you all with zirconia because I think it is not just the future, but now it is kind of the current anterior aesthetic restoration. I think there'll probably be different things that come through in the posterior as time goes on, but the anterior zirconia is going to be really hard to beat aesthetically. So just getting your head wrapped around that, I think, is important. Being able to do aesthetic restorations in the anterior. As I mentioned before, choose your crown size. And if you don't use New Smile and you don't have the pink try-in crowns, then just take whatever company you do use and just choose one of those crowns and say, okay, I'm going to use this to figure out what size this is. And you can even make one of those your own try-in if that's what you want to do, because it's letting that one do all the dirty work and do all the difficult things, then going in afterwards and being able to take a brand new, clean, beautiful crown out of the box. It's never been autoclaved, never been used on another patient, and then cleaned and reused. These are all brand new. That's the one you want to cement. You want to eliminate all the other possibilities of failure from contamination. You do have to have a passive fit. So you don't want to force that try-in in. It's got to be passive. And what I mean by that is if you have your abutment tooth or your substrate, you're going to take that crown and you're going to choose your ideal path of insertion and try and come down over that preparation. Wherever you're getting interferences, you're just going to come off and prep that one little spot. Don't just grind down the whole tooth, figure out, okay, where am I binding? Which particular place is it? For most people, it usually is wherever you can see the kind of have the worst view. Typically it's the lingual or the distal lingual. On anterior teeth, it's typically a cingulum that's in the way. On the posterior tooth, it's usually some buccal bulge that's in the way, or potentially some accessory cusp that isn't average. If you feel like you're having an interference, and you're going to come off and get rid of that interference, and then once you get down on the tooth, and I don't know if all you can see, but I want to be able to come on that tooth, and then, okay, I'm in the right position, and I want to have just a little bit of movement. That's what I mean by passive. You don't want to be able to turn it. You don't want it to be loose. I want to be able to come in and then just have a little bit of leeway. You don't want to be able to spin it. You also don't want to be stuck. If you have to use an instrument to take your crown off on a zirconia crown, it's too tight. That means you're binding somewhere. So figure out where that bind is. Just take your diamond and do just a quick preparation so that you have a little bit of movement there. And then that'll be filled in with your eluting cement, and you're going to be able to position that in the right place that you need to. It also means you have eluting cement all the way around the tooth on that internal surface. All the line angles smooth and rounded. I think this is one of the major reasons people do get stuck. Is it's not always just like some kind of actual area that you need to go and take off a large piece of tooth structure. A lot of times it's just that there's some sharp line angle you just have a 90-degree angle someplace on one of your occlusal line angles, or maybe there's some line angle that's a vertical on an axial wall that just needs to be smooth. So getting rid of all of those rough surfaces or any kind of point angles, a lot of times it'll just slide right on there. And that'll be the same for your stainless steel crowns too. If you feel like you just aren't rolling on those, if you just smooth all those edges so that everything is just smooth, I don't mean rounded, don't make a bunch of domes, but if you just have all those line angles and all those point angles are nice and just smooth, then even your stainless steel crowns are going to tend to roll on there and snap on a little bit better. Zirconia crowns, if you look on the internal surface of the tooth, you'll see that all of them are soft. They're all soft, they're all smooth. So it's not a 90 on a 90. You want to make sure you get all those things nice and smooth. That's going to save you a lot of frustrations. In the anterior, be careful not to exaggerate your preparation. A lot of times what will happen in the anterior is people will use a tapered burr and they kind of lean into the preparation. As you lean into that, you go from having a tooth that has kind of a normal shape to that, and then you end up with having a wide base at the gingival, and then you have a really pointy top at the incisal, and then you end up just having this long slope, when really all you want to do is take off a millimeter all the way around the tooth. So a millimeter on the occlusal, on the mesial, on the distal, on the buccal, on the lingual. That's what you want to do, is just take off as much as you're going to replace. And if you'll do that, you'll find that you have more tooth structure when you get finished. Your bonding will be stronger. Your tooth will be able to withstand a lot harder forces. Much better to do it that way. So you want to just take off a millimeter everywhere that you're working. Don't lean into the tooth and make it this pointy thing. And then you have to do a nerve treatment, and now you've compromised the tooth. So be mindful of that, because a lot of times, especially if you're working in the posterior or through a mirror, when you start to do that, you don't even realize you're starting to lean a little bit. So just take your mirror, pull back a few inches, and just check the angle of your burr. Again, I do a lot of these restorations, and even that sometimes I'm doing my prep in the posterior, and I just pull out and I'm like, oh, okay, I just need to move it a little bit, because you're working upside down and backwards, and you've got water spraying all over the place, and the kid's moving around. There's a lot going on there. So just be mindful of the angle of your burr, and I think you can avoid that. This one also, I think this is where 10 years ago, I've been doing zirconia for 13 years now. 10 years ago, zirconia kind of got a hard time, because a lot of people were having abscesses, and of course zirconia was blamed, which is kind of a weird thing to blame it on, but we were having, I think, a lot of inadvertent or unknown exposures of pulps, where there were micro exposures, where instead of understanding the concept of, okay, this whole restoration circumferentially is 1 millimeter, so take 1 millimeter tooth structure off. Wherever you don't have a millimeter, that's where you're going to get stuck, and that's where you need to focus. And I think a lot of times people were getting frustrated, and they just kept prepping, and so you're just going down occlusally. Now you're finding a micro exposure and a pulp where you didn't realize. A lot of times people would feel like they were getting stuck in the gingiva. Well, then they start prepping even more subgingivally, when really all you need to do is get past the height of contour. So as long as you're past the height of contour, you really should just be going from the CEJ and up should be all your preparation. Sometimes with a compromised tooth, you might go a little bit lower, but I think a lot of times the burr will end up down in the sulcus, and then all of a sudden you're down in the bone, and now you're in a furcation, and you are going to have a failure. Or if you are prepping too much occlusally and you've got a young tooth, and you're not paying attention to a pulp horn, then on a young tooth without the mature dental tubules that have given secondary and tertiary dentin protection to the tooth, a micro exposure is quite possible. So be mindful of those things. Mostly just understand the concept of all you want to do is take off as much as you're putting back. If you're putting on a 1 millimeter restoration, don't take off 2 millimeters of tooth structure. And if you can do that, you'll find yourself in a lot safer position for a lot of those different things. Game plan for hemostasis, I think, is very important. As I've talked about contamination already, you really need to give yourself a minute to say, okay, if I'm going to make this bleed, do I have 2 minutes to allow natural hemostasis to take place? Do I want to use some kind of hemostatic agent? Or am I going to use, inject some local with epi in there, which is what I do most of the time, but give yourself a chance to get that bleeding under control if you're going to have subgingival preparations. Going back to the last slide and what I was just saying about the preparation, the whole goal, of course, is to stay out of the sulcus. A lot of the bleeding should only happen if you have subgingival or paragingival caries. You really shouldn't be causing bleeding just for the sake of these crowns. Really, the preparation should be able to stay out of those areas. And then put your crowns in the same way that you tried them in. If you did KNL, then cement them as KNL. Don't try KNL in and then all of a sudden try and go L and K for whatever reason. Sometimes those physics don't work. So just always stay in the same sequence. I would recommend that with your stainless steel crowns too, especially if you're used to kind of pushing them a little bit, because those mesial and distals will kind of change a little bit of their shape. You really want to see a cement collar, and I would encourage this for all of your luting agents, all of your indirect restorations, that you really want to see a really light collar of cement that goes all the way around the tooth, so you know that you've filled all of the voids as a luting agent. If you don't see, if you don't see that there's cement coming out on the buccal or lingual, that probably means there's a defect in there, which means you're going to get food, you're going to get plaque, you're going to eventually get some failure or potentially an abscess on that too. So the cement collar, I think, is good for all indirect restorations. And I don't mean waste cement. Trust me, I'm the last guy that likes to waste materials. But I really don't like my dentistry failing. So you want to make sure that you at least have that luting agent go all the way around the tooth and have a little bit of a collar go all the way around. For zirconia in particular, where it's all of a cement retained restoration, you're really at the mercy of how well that chemical adhesion is going to happen. You've got to make sure you have a good collar all the way around there so that you're well luted. And then, if you're not comfortable doing these yet and you're not quite sure if this is going to be a candidate for a zirconia crown, then let the parents know preoperatively that, you're not quite sure. Maybe, hey, I think this is going to work, but, your son or daughter may not be able to have this particular procedure. I might have to do the historic white facing crown. I might have to do the stainless steel crown on the posterior. I might have to, do a strip crown or something. Give yourself a fallback, give yourself an option. So if you get in there and you kind of get in over your head and you're frustrated and you haven't overpromised the case, you give yourself a little fallback. And then we've already talked quite a bit about enameloplasty and some fluoride if you need to. If cement failure occurs, which I think is where most people tend to have an issue, when I start talking to people on post-op and they're getting frustrated because their crowns are coming off and so forth, it's almost always a cement failure, which is what that last slide was about. We got to make sure we have heme control, saliva control. You don't have to have like a dry tooth. In fact, you don't really want a dry tooth. You almost want a little bit of a glisten so you know that those dental tubules are moist and that they're not collapsing to protect themselves. So you really want to spritz it with some water right before you cement. That's the beauty of the cement that I use with the NuSmile. Also with your RMGIs, they should be able to handle that. In fact, that's how they thrive and do their best. But what you do want to do is you got to beat the blood. And so if you have some bleeding coming in, sometimes I'll have these hyperemic tissues, and my staff will even be blowing air on the tooth as I slap that crown on there with these zirconia crowns. As long as I beat the blood, I win. So the cement is much thicker than the blood, so it's not going to wash out. It's not going to be an issue. So as long as the cement gets there before the blood, you should be fine. And then just understanding your cement, type of cement, making sure you've got the ability to get a good bond on there. If they have a failure, of course, with their candy or food or an accident or whatever else. So I say know your cement. It's probably one of my most emphatic points, I think, for indirect bonding is just know your cement. If you love Key-Tac and you want to keep using a glass ionomer only, that's fine. Just know how it works. Know how it works when it's wet. Know what its resistance is when it's challenged by candy. If you want to use RMGIs, you want to use a true resin cement. I like BioSem, which is NuSmile's product. Just know your cement. I'm not going to spend a whole lot of time on this preparation here. This is a placemat that Preston can easily just send you all, or someone from NuSmile, Zoe, or someone can just send you this PDF, and you can use this to kind of look at all the different steps. This is our training model of how you do these preparations to get that 1 millimeter that I've talked about, how to do your uniform preparation without taking extra tooth structure. Again, not going to spend a whole lot of time on that. To give you an example, here's even a placemat I just pulled off one of my colleagues' desks. They had it, they don't like take it into the operatory with them, but this is that posterior on one side, anterior on the other. If you want to take a quick look at that before you go into a procedure, or if you want to laminate it and take it with you, for those of you who are much more humble than most of us, and you can look at that as you go. These are the burrs that NuSmile offers to do those preparations. Again, not going to spend a ton of time on this. A lot of times we do these courses in person, and you get to actually go through and do these on models right afterwards. But that'll be either for another event, or if you want to buy their burrs. They're not a money maker for NuSmile. It's just kind of the cost of a burr. So these are the burrs that they typically use that will walk you through that express prep that I just showed you, and that you'll be able to get that. So these are the preparations and sizable depth cuts. Again, you don't have to do depth cuts. Some of you will feel like you're kind of in a younger training period that someone's telling you how to do depth cuts, but really this is just to show you, okay, take a millimeter off. Now do your axial preparation, staying parallel along axis of the tooth. Great contact. Now do a little shoulder all the way around the tooth. Remove that cingulum because that's where you're likely going to get your interferences. And now try the crown in supragingivally. You should be able to get to that margin that you prepared in the previous step. And if you can't, then your interference is supragingival to that. Hopefully nothing's bleeding yet. That's the whole concept of that. Before things start bleeding, you have 90% of your preparation done. And then you take a fine diamond and remove that shoulder subgingivally. Keeping all these nice rounded line angles is, of course, the goal, and to avoid those interferences. Now you should be able to fully seat that, take your white crown out and cement it in there. So that's kind of the gist of that preparation. Again, we can send you that placemat. We can send you all those steps. That's not an issue at all. I'm not going to spend a ton of time on that because we're not doing those preparations today. Going on to some of the more challenging cases, the lower anteriors, you got to get up close and personal with these. For new smile, they don't have a left and a right. They don't have a central and lateral. They're called universals. And so on the back of that crown, on that inscription, you'll see a U on there. So it's U1, 2, 3, 4. Typically, centrals are a size smaller than the laterals. Just anatomically, that's the case. Sometimes all four of them are the same size. Just whatever they come in with is what I want to send them home with. Particularly on there where we have so much lower anterior crowding, you really don't want to put a bigger crown on there because you will cause that lateral to come in and get stuck and have to extract your tooth. So on canines or cuspids, always watch the contralateral side. I think that's very important. Always make sure you're aware of what the angulation is over there. Does it have a little rotation? Does maxillary have that mesial inclination we expect? Is the lower vertical, or does it have some kind of rotation? That's why I like to do the left side and the right side, because I can pull the other side back and just look at it, and then I just match it. Then I go to the other side and match the one I just created. So that's how I do those. But cuspids, canines, they're obviously the point of contact where the most stresses tend to go. If we think through our lateral scursive and anterior protrusive movements, that's where all the disclusion typically happens. And so if you're doing a full mouth case, I don't love my first point of contact and my main disclusion contact to be the canines. I really want to try and put some of those forces onto the molars. So I'll usually kind of prep those a little bit more. So I almost create a group function between the canines and the posterior for some of those pressures. Remember the cingulum, that's likely the reason that you can't get that you put your crown on and it rotates a little bit at the last second. Usually the cingulum or subgingival, some kind of small subgingival interference is happening. And then, as I mentioned earlier, I recommend anterior posterior being done separately on those full mouth cases. Excuse me. And by separate, I mean that I would recommend doing those, cementing one in place, and then carrying on with your case, doing it all the same day, but just doing those with a point of reference. Here's the posterior express prep. Again, same kind of thing, just a training thing. This is on the back side of the placemat. Preston can send that to you. But here's the burr kit. You can see these, really all it is you've got about 1 millimeter at the thickness of the hub. You've got a little bit, about a 0.5 millimeter at the tip here. So you're just using those to do that millimeter reduction to get the nice taper that we would like to have ideally on the shape of these teeth. And then that green stripe, which is your subgingival burr, which you can be a little less aggressive on those tissues. If you do an occlusal reduction, functional reduction, axial wall, kind of depth cuts if you want to, or you just create a shoulder all the way around the tooth effectively. Now you want to be able to get your crown to go and rest on that shoulder. Again, if there's any interference of supragingival to that or supracoronal to that shoulder, and that will tell you that's where your interference is. And then we'll take our green stripe diamond. I'm sorry, there's your test fit. And then we take our green stripe diamond and go ahead and remove that shoulder all the way around. Take your Explorer, click it all the way around the tooth. Make sure you're not having anything that's stopping you from seeing that crown. If so, then just take your diamond and focus on that one position. Again, if you feel like you're getting stuck, don't just take the burr and just go all the way around the tooth over and over again, because a lot of times that is going to be when you find a furcation where you end up getting a pulp exposure you're not expecting, and you're just removing tooth structure you don't need to. So try and be a little bit judicious on that. Obviously, you can do that. You can get away with it. On an older patient, you tend to do that a little bit better. Again, once you have secondary, tertiary, dentin underneath there, then a lot of times your nerves have retracted a little bit and you have a little bit more of a dental space to do these preparations. But on a young patient, please be mindful of those pulps, because they will come back and haunt you. If you don't, they'll come back and say hello someday. As far as pulp, and that's kind of what I was just talking about too, is, do you have to do a pulpotomy on all these posterior teeth and all these anterior teeth? You don't have to, of course. You only have to do whatever you would on any other tooth. And so if you feel like the caries is deep and approaching the pulp, and you're not going to be able to seal that off properly, then a pulp is likely going to be an issue. If you feel like the patient is 2 or 3 years old and those pulp horns and our proximity to the dentin and the enamel, by the time you do a 1 millimeter preparation, you're going to be touching one of those pulp horns, then doing a pulp is going to be definitely in your favor. So just be mindful of that. If you feel like it's blushing, you're really close to that, I think you'd be much better off doing a crown, doing a crown under general anesthesia that's aesthetic and the parents are paying for. You definitely don't want those to fail. So in my case, I look at the tooth, particularly in the posterior, and I say, okay, should I pulp this? I don't know. Should I pulp this? Probably pretty close. Should I pulp this? Yes, it's probably time to pulp that, or do an indirect pulp cap, put something on there, some kind of MTA product, something that will cause some secondary dentin to form. You put some calcium hydroxide or MTA, whatever it is you want to do, some kind of a barrier on there, something that will cause that pulp to protect itself, because an abscess on a beautiful crown is really a heartbreak, and it makes parents very upset. For those of you who love that scenario, you know exactly what I'm talking about. So bottom line on pulp therapy with these is treat these teeth just as you would any other tooth, where you're doing a continual diagnosis before, during, and after preparation. So obviously look using your x-rays, understanding the age of the patient, growth and development. You know, a patient that's got a toroodont and giant pulp chambers is going to be different than an 8-year-old that's got an MODBL lesion that just needs a crown on top of that. So those are all very different things. So just be aware of that. Of course, planning it, getting it approved, making sure the parents know it's possible, having the insurance figured out, and then not having to do that is a much better option than the opposite. So I'm getting those things at least as a potential at the forefront. Hemorrhage control, as I mentioned before, this is critical. And most of the time, you can beat it with some air and water, and just getting there before the blood gets there. But I really don't like my crowns failing, and so if I can possibly do it without any blood, that is my goal. These are the options that I think through. Either pressure, you can kind of hold that, or move to another area for 2 or 3 minutes while the bleeding stops. If you go and do your pulpotomies or go and polish some teeth, whatever, while the bleeding stops. Be careful with pressure. I don't love the pressure concept, because you're obviously putting a crown down in a gingival sulcus is the goal. And so if you collapse that sulcus by pushing things together and getting the bleeding to stop, then you have to open that sulcus to get down subgingival again to get your emergence profile. You just open that bleeding right back up again. So I don't love pressure for crowns, but it is an option. Superoxyl, ferric sulfate, hydrogen peroxide, these are all options. I call these kind of third-party agents, where you rub those around the tooth and stop the bleeding. I'm a little bit wary on some of them, because you're rubbing those around your dental tubules. And so if you're rubbing a gel inside of a dental tubule, obviously your bonding can be a little bit compromised. So make sure you rinse that really well afterwards, or even just take your diamond burr and some water and just go around it real fast and just open those tubules back up again without really prepping the tooth, so you can get a better strong on that again. An interpapillary injection of a vasoconstrictor, which of course is a big word for just saying lidocaine, right? We've all got this chair side, we're already using that. So the whole goal of that for me is just making the tissues blanch, which means there's no blood flow to those areas. Yes, there's a secondary effect of epinephrine maybe causing some vasoconstriction, but that's really not my primary goal. My goal is making things blanch. Blanching means no blood flow. Blood flow means my bonding is going to work better. So that's really my whole concept. I did it on a composite too. Sometimes if I have subgingival on a composite, just take that needle and make that tissue blanch, and it'll give you your 90 seconds to get your composite done. Viscostat Clear is another option. It is a third party, just like the ones 2 lines up above. To me, the big difference on the Viscostat Clear is that it doesn't discolor the tissue. So if you use ferric sulfate, it sometimes will leave the tissue a little bit orange, and post-operatively, some of the parents will kind of grind that axe, but it's really not worth that. I would rather just use a Viscostat Clear. It doesn't change the tissue color, or just give them a heads up of what it is. Either way, just address that. Retraction cord. This is one of those. I have met a couple of pediatric dentists now that use retraction cord when they do their crowns. They are much better than I am, or more mindful, or more willing, gluttons for hard work. I don't know, but I don't do retraction cord. I don't find the necessity of that, but it would definitely work really well if you needed it too. So absolutely no reason you can't do that. Cautery. Some of you have lasers if you want to get a little bit of blood control with using some laser or cautery. And then of course sutures. If you really needed to, you could suture some stuff, as I mentioned on that one slide earlier. For me, that's reapproximating tissue. That's not for blood control, but you could certainly do that. For cementation, what do we use for cementation? I use Biocem for all my zirconia. I have used these other ones as well. Biocem is New Smile's own product. Of course, I think a lot of you probably use Ketac still. Ketac works really well because it works in moist environments. It does great with a little bit of bleeding. It does great with a little bit of saliva and some water. Ketac's very, very forgiving. The challenge with Ketac is it's not very strong on a pure chemical retention. It works great when you have a snap fit, where you've got a crown that's snapping on there. It's got mechanical and then it has chemical, but on its own as a standalone, it makes me a little bit nervous, but it tends to work for a lot of people. So as I said earlier, just know your cement. I don't care what cement you use, just know your cement so that when it fails, you know what happened. Because it will fail. I don't say that, demeaning. It's just the way it's going to happen. Sometimes things are going to come off. Fujisem 2 is what I use on all my stainless steel crowns, my space maintainers, most of my space maintainers, my stainless steel crowns. And then Biocem is what I use on all my zirconia, because it's a light cure, it's a dual cure, has all the properties of a Fujisem and an RMGI. And I love my light cure material. Reliax, some of you, but this is one that I used to use before New Smile came up with their own product. Reliax is a great cement. Works really, really well. A little more expensive for my taste for pediatric teeth. this is what I've kind of alluded to a couple of different times, is this is kind of our cool geek out slide where us as dentists understand the biochemistry of how our cements work. Where you have your crown. If you look on the top left here, this is our crown, whatever your choice is. These are your cement little particles and your little soldiers. And then this is the dentin of the tooth. So we're trying to get these particles to attach to the crown, get through this luting layer. Whatever's on the bonding surface of the tooth, you're going to foodstuffs, water, whatever it is. And then we don't want to get these tissue tags to attach. We want to get down to these dentinal tubules. So this is biosem at 24 hours. This is biosem at 72 hours. And you can see how these little I call them soldiers, have gotten down here behind these dentin enemy lines and getting a nice strong contact there. So as you saw that spin in on there, remember this happens on all your cementations. That's why you can't just slap a crown back on that's been off for 3 days without cleaning the tooth. You just got to clean it off. There's foodstuffs on there. There's things that are going to stop that and it's going to come off again. So clean that real quick. Even if you're just re-cementing someone's stainless steel crown, at least take at a minimum, a 2x2 damp gauze and just wipe it off really well. Ideally, you would actually clean off the substrate and get it nice and prepared to accept your cement again. So again, know your type of cement. Not going to spend a ton of time on this. This is your GI, about 10 kilograms of retention. You know your retention values so that Halloween's what, 3-4 weeks out. When kids come into you the day afterwards and you used a GI on something and it came off, don't be too surprised because you've got only 10 kilograms of retention. RMGIs, you get about 15. A pure resin cement, which is what those of us who haven't ever had a crown, or if you've ever placed a crown on a permanent tooth, they're probably using a resin cement, which is your ideal bonding situation with a cooperative patient without saliva, without bleeding, and so forth. Biosem and Ceromere give you about 20 kilograms of retention, which is why I like to choose that over the other ones. This is just a nice little reminder for everybody, whether you're using ZOE or IRM or any of those other materials. If something has eugenol, if it's a eugenol-based product, and you're putting it with a resin cement, be mindful of that they don't like each other. So that's oil and water trying to get together. So just be mindful of that, where you don't have a giant tooth full of IRM and ZOE, and then you put a pure resin on top of that, because that bonding is not going to be very strong. But just try to have your contact point as best as possible with some kind of RMGI or the glass ionomer, and then your cement, or you can use even Tempit or something if you want to. That's a whole nother discussion, but Tempit, I think, is only to be used at surface levels. I don't like Tempit anywhere near a pulp, but it does work really well between MTA and then my RMGI and then my biosem. Anyhow, that's enough about cement, but I think that is where people really get frustrated is debonding. There's being able to prep the tooth, which is the goal of the hands-on courses, but also walking through the concepts of, okay, wrapping my head around, I need to prep this tooth to fit this crown, taking off this much tooth structure. And then the next part would be being able to get the tooth to stay on there. Those are where most people's frustrations happen. And then being mindful of the pulp therapy, which we've already talked about, because that's where you'll get your spontaneous, or unexpected, I should say, exposures, where all of a sudden they come in and you've got an abscess and you just, it's beautiful crown, but now you've got a furcation involvement and so forth. So I'm not going to spend a lot of time on these. This is Biosem New Smiles proprietary product for Zirconia. Again, I love it. It works out really well. I've done it a lot of different times. I've used all the different cements that you can think of. This is where I default to. This is that cement collar I was talking about. And I really want to see this on my stainless steel crowns, on my white facing crowns, anything that I do that uses a luting agent. You really want to see that collar. That is an insurance policy on ever having to re-cement that tooth. These instructions for use come in every cement. If you ever buy that stuff, you can look through those and do those. So advanced questionable zirconia. So don't judge me on this case. I'm going to share a couple of cases with you, and you may say I'm crazy, never should have done it, should have extracted them, and I'm good with that. But I want to talk you through some of these concepts, so that some of you that start to do a little bit more complex cases, maybe you can understand some of these things. So here we have fused teeth in the upper anterior. This one's a fairly basic one where you just got a really big, it looks like a really big upper front central incisor. These are fused teeth together. Parents want to keep those. I want to give them the option to. Again, not my very favorite one, but is this better than a giant hole? Is this better than a giant space in the front of these teeth? Some of you would say, yes, it probably is. You'd rather just take the teeth out, and I can understand that. And then do you take out all 4 of them or slash 2 of them? Or can we give them something? If this is what you started out with, is this something that's okay to end with? And then you can see up here, this is bruising from my injection. So don't get too caught up on that. But this is a case where we wanted to save that upper front tooth. Again, not my favorite, but one I wanted to share with you. I'm going to share another one with you that's a little more advanced. and it was kind of fun to do. And it actually, as far as I know, worked out really well. Some of the recalls after 2 visits, I wasn't able to see them again, but this one was a little more advanced. And most of you would have extracted these. I would have preferred to extract these. Candidly, I would much rather just take these teeth out and not try to do some questionable heroic dentistry on this. But this was one of the parents who really wanted to keep these upper front teeth. Any of you who do flippers or do pediatric partials know how miserable those are, and anything I can do to avoid those. If it's a parent that's going to demand that I do a partial on an uncooperative child, then I really try to see if I can do something that bombs well and I can get a result. So here's our pre-op clinical, pre-op x-ray. You can see we do have a couple of different pulps on here. The caries are severe. Again, I don't disagree with anybody wanting to extract these. I was trying to just to go ahead and excavate the caries and see if I could just do a really large composite or something instead of trying to crown these teeth. But there we got into the pulp. And so I thought, what the heck, we'll go for that. Worst case scenario, I do a lot of conscious sedation. I'll just take them out for free in my office. We'll try and get mom a result that she wants. So here's my preparation. Left side first, and I went ahead and did 2 crowns on here, which again, I know some of you are going to say that's crazy, it's irresponsible, I understand all that, but this is an advanced zirconia discussion. So then I went ahead and cemented those. As you can see, I did those a little bit shorter. I had to fit 2 crowns in one space, and so I can't just say what's the mesial-distal dimension to make it fit, because I'm essentially using the fused spot to have 2 millimeters of zirconia. So I'm sizing those down a little bit. Again, we're going for aesthetics and a little bit of function here, but we're definitely not trying to restore an ideal smile. But here's the left side. Seemed to go pretty well. Went ahead and prepped the right side, same kind of thing. And you can see if you get up close and personal here that we were able to go to where we can see these teeth are fused. We have 2 different preparations side by side. In this case, you will have to do a little bit more of a reduction between those teeth, of course, to get a millimeter off each one of them, treating each one of them independently. You may even have to use a lateral for a central and so forth if you venture into these types of cases. And then here's our immediate post-op on that case, where you can see if you didn't know better, and definitely if you were just kind of an average person hanging out, didn't know dentistry, then you would say, oh, that's interesting. He's got a big space in his front teeth. But you'd be more worried about the diastema. You would probably have no idea about the central lateral connection there. So here's our immediate post-op. As you can see, I had to do pulpectomies on these. Actually worked out really well. I was able to get them in for an immediate 14-day post-op. I was able to see them at 6 months, but I didn't get to see them any further after that. They fell off the map. So anyways, kind of a fun case, interesting case, certainly controversial case, I'm sure, for some people, which is fine. It's nice to do something outside of the box and have a little bit of fun sometimes. As you can see, out of paranoia on these lower anteriors, a lot of times when I'm edge to edge, I'll just do a little disking on those and put some fluoride in there. As you can see how tight these were together, and certainly a very high caries rate. So we just do we call it disking, but a manicure. That's a no charge code in our office. So anyhow, that case, again, I know some of you may have a big opinion about that, and I can respect that, and I'm happy to chat through it. But here's my babies. There's my wife and kiddos. This was the night before last. My little Elizabeth here turned 1 year old, and it was a pretty fun night. So exciting to see how fast they grow and how crazy it all happens. I think most of you are very familiar with how quick life will get away from you. But I do think this is a very exciting time, as you can see from that case I just shared with you, to be able to do some fun stuff that is outside of the box, maybe a little edgy. But as long as you have the ability to recover from that, you're willing to take a hit in the pocketbook and do some free dentistry to recover from that, or maybe do your first case or 2 at a reduced fee so that you can get comfortable and get some confidence doing these cases. Those are all different things that I've done through the years to try and get comfortable being able to make better predictions and better treatment plan options to families and patients that come see us. So I do think it's a very fun time to be part of all these things. So this might be the first time I've ever ended on time, and in fact about 90 seconds early. So we made it to the question section. I do have a video, but it's way too long to play on a Wednesday night. So we'll wrap it up here, and I'll go to questions.
Yeah, Dr. Evans, I was going to give you a hell of a job on timing, man. That was you're right there. So, but yes, for all of the members that are online right now, if you want in the chat box, or I can see a few of you already have in the QA. Dr. Evans, I don't know if you can see it, but if I'll go ahead and read the first one. I find the new smile crowns are too long occasionally. How do you handle that?
I can say that again. I'm trying to find that too, but
yeah,
what?
So I find the new smile crowns are too long occasionally. How do you handle that?
Too long.
Mm-hmm.
I too long would not be an issue that I deal with very often. Sometimes if you've got a patient that's bruxing and maybe grinding those teeth down a little bit. I could see where that happens. When I have had them long, what I do with those is I actually take the crown into my fingers really tight after I do my try-in and figure out which size it's going to be, mesial distal, and then I take that crown that I'm actually going to cement. I take a diamond burr, I turn on the water, and then I go over the top of some kind of container. I actually will grind down the gingival edge to make the crown a little bit shorter. So you've got about 1 millimeter on the incisal edge. Sometimes that's my first choice. If I'm only talking, 1/4 millimeter, maybe up to 1/2 millimeter to get it to match an adjacent tooth. But if I really feel like I need to get a full millimeter, then I'll actually take it off the gingival side and shorten that crown myself, similar to the way that I would with a stainless steel crown in the posterior where I trim them, but I trim it with a diamond burr with the water on, away from the oxygen. So I don't have it very often, but I do appreciate that question because I've experienced it, I've done it, and that's how I deal with it.
All right, thank you, Dr. McIntosh. Next question I have, Dr. Evans, is Dr. Johnson. Do you ever use cavity conditioner? Sorry, let me start over. Do you ever use cavity conditioner to improve bonding on the biosim if hemorrhaging's not an issue?
If you had contamination, then I could see that being a problem. I've never had to use a conditioner. Fortunately, that's just a step I don't do because we use a brand new crown every time we cement. Even if I'm in the middle of cementing and I've already done like my cure, it's starting to set up, I'll just take that crown and set it aside, take a brand new one out, fill that one and cement it, and then I can take the one and clean that out later and autoclave it and reuse it. But I really haven't had to use a conditioner. I can definitely appreciate that. Usually just preparing the tooth and getting all of that kind of, I guess it's probably kind of some kind of a smear layer or something off of there. Is all happening because I cut with water and it tends to rinse really well in a water with high-speed diamond. I don't have anything against it. I just never needed it. I've had people ask about using like etch. Do I ever etch the substrate to bond on there to open up those tubules? I definitely don't do that. I don't love the idea of etch because it can be an irritant, a nerve irritant. And so I want to be careful that I'm not going to create a hypersensitive tooth by disturbing those dentinal tubules. But mostly I just don't need it. So I've never had that. I've done a lot of things to work on my bonding and to try and increase and improve my success, but I've never had to deal with any kind of conditioner. It's just another step that I wouldn't want to do on a patient that's about to lose it. But I understand the concept. I haven't ever needed it. If your crowns were contaminated, I could see that, or if you had a dirty substrate maybe, but with those two things eliminated, I wouldn't do that myself, but nothing wrong with it.
Okay, awesome. Thank you, Dr. Johnson. Next question, Dr. McIntosh. Do you smooth the margin after the diamond burr?
I smooth the margin after the diamond. Only if I'm getting stuck somewhere. So as long as the everything is already rounded off. If I feel like I'm getting stuck somewhere, a lot of times you'll see, and if I shared that video, you'd see that a lot of times, like as they're cementing for me, I'll just take my burr and just do a quick once around just to make sure I don't have any edges, because I usually feel like I'm already there. But what I don't want is a last minute interference where right as I go to seat the crown, it just turns me right at the last second, or it just pops up my mesial or distal, and now I'm not in the arch form. So I try to get rid of those beforehand, but I would say at the last second, sometimes I just check all those margins as the staff are cementing those crowns.
Okay. Next we have from Dr. Lopez. Is how often are you doing these zirconia crowns chair side with nitrous alone?
Not very often. So, and it's not that they couldn't be. Dr. Johnson, Dr. Laurie Johnson, does these routinely. She does them every day. She's not a big OR or sedation person. I just do a lot of sedation. So we do a lot of sedation. It's kind of what we're known for. It's where a lot of our big cases come from. It's what people ask me to do. I do them. I'll do a single tooth. I wouldn't do D through G, maybe ENF on a cooperative 5-year-old or 4 or 5-year-old, but I'll do K, I'll do T, I'll do A, I'll do J, I'll do 1 or 2, but I don't do full mouth chair side. But if you do quadrant dentistry and you wanted to do 1 or 2 of these at a time, there's no reason you couldn't. I've certainly done a lot of that in the past, but I just don't do them. Not because I'm averse to it. I just physically, I only do nitrous occasionally because we've got a big practice and I do a lot of the full mouth stuff. So there's no reason you couldn't. You just want to get your speed up. I wouldn't do it the first day if you haven't ever done it before. Please don't sit down and give yourself a multiple posterior or even a large anterior case on a potentially uncooperative patient. You don't want to predict some patient behavior so that you'll be successful the first time. There's no reason you couldn't. I mean, I would do it. It takes me about twice as long as a stainless steel crown. Maybe if I do a stainless steel, a lot of you a stainless steel crown, probably in 90 seconds or 2 minutes. A posterior zirconia crown probably takes me about 5 to 6 minutes, isolated by itself. Back to back, maybe 8 minutes together. So you could definitely do that. It's just, you just got to have all these other parameters. There's a lot of we don't see new patients over a certain age also. And so a lot of our restorative is just limited to younger patients with bigger cases.
Okay. Next question, Dr. Abad. What material do you use to seal the crown if you have to make an occlusal access after you made a crown with pulp complications? With pulp complications, yeah.
That again, sorry. Can you read that back?
Yeah, sure. What material do you use to seal the crown if you have to make an occlusal access after you made a crown with pulpal complications?
Like a retreat through the occlusal? It sounds like that's the question. I actually, when I've done that, I've actually opened those up. I don't love compromising that occlusal. So I would rather just do what I've done on those. I would rather just replace the crown at cost to the parents. Let them pay the $28 or whatever it is, or just eat the $28. I would rather just pop that crown off and redo it. You can do it, and I've seen it done. I've even done it. I've done it through the lingual of the anterior, where I noticed that that I didn't get a pulpectomy where I needed one, and I've accessed through the lingual and done that. It just makes me very wary because the zirconia is so strong with compressive forces. It does really, really well with compressive forces, anything that hits it from the outside. But expansive forces, it's just not that strong. That's where you really have an issue. So that's why if you force a crown on, a lot of times it will fracture. But once you get that crown on there and you cement it and you have it well fitted, I mean, you could hit that thing with a hammer and it's very unlikely to break. So they're incredibly strong. Anytime that I break that material and that matrix that's going on with zirconia, it makes me very wary. So if you're going to have a several $100 crown that you cut a hole to the top of, given that our crowns are $25 to $30 in pediatric zirconia, I would rather just pop the crown off and put a new one on, because I can do that very quickly and feel a lot more comfortable with that. But you can do it. I don't love doing that. And you could do it with a resin, would probably be the right thing to do over the top of that. Composite is what I know some of the colleagues do. They bond to that and put a composite on there. Typically, if you're going to do that and try and bond to or around a zirconia crown, then you need to use a different type of edge. So probably need to use hydrofluoric acid or a stronger etch that's made for porcelain or that's made for zirconia. Not your typical prime and bond for a composite. But again, I would just pop the crown off and put it on. I'd rather eat $28 than have a crown fracture and break, and then now I've got a broken tooth and a potential extraction. But you could do it. It's not my go-to.
Okay. Awesome. Answered his question. Okay, let's see if we have any more. Okay. What's the average fee one charges for posterior ZR, Dr. May?
Man, it's I wouldn't call it a personal question, but some people would. Our fee for a posterior zirconia crown is about $500. So between $400 and $500 is typically what I hear. There's people that I know that are in some nice areas in Florida that charge $900 or $1,000. Ours is I think $479. I don't know. You could do a fake patient visit and get it on me, but I think it's around that. Some of the insurance companies are paying for that, which isn't awesome because you get their fee. But around 500, I would say across the country is probably the average. I know some people are doing it for like $350. Some people are at $700 or $800, $900, but I think probably 500 plus or minus 50 is where most people are entering their patient profiles.
Yeah, and I can piggyback on that a little bit too, just from my end too. I've seen from most of our customers ranging from around the country, $250 to $350 more than an SSC. As I've seen that as well on average too. So, okay, next question. I have Dr. Lynn. How do you pop off zirconia crown if you had to retreat to do a pulp?
Yeah, and I should have taken a couple pictures for you all. This is a common question. Fortunately, it's not very often, but it's also not difficult at all. People get scared of it. I think the biggest fear most folks have is they're worried about like a spark or something happening. You just turn your water on, and I section it just like I do a stainless steel crown or anything else. I just come onto the tooth. If this is the tooth, I just come onto the facial or the buccal, take my diamond burr high speed with water, and I just go, and then it finally just pops through. And at that point, you just take any kind of flat instrument and rotate it, and it'll just pop off. So it is not difficult to get off once you break that. You just have to break that occlusal gingival dimension, and then it will just pop off. You can roll it off. So you actually just need to be ready to get all the pieces so they don't go anywhere. Because once you break that, again, it's very, very strong. But once you break it, then it will come off very easily, which is why retreating makes me a little nervous. But you can pop them off pretty easy once you break that bond. Another option that the other clinicians do, I know some of our lecturers even do, is they just take like a 45 Hal or a forceps and they just shatter the crown. They just go on the tooth and just pop it. Obviously, there's a lot of reasons I don't love that. Mostly just trying to find all the pieces and make sure I don't have somebody swallowing or aspirating something. But that's an option. Just shatter it and pick up all the pieces with an eye slide in or something else. I would rather just pop it off.
Okay, awesome. Next question. So Dr. McIntosh, if the NuSmile Biosim doesn't bond, I've gone old school with Durolin. Make sure I'm pronouncing that correct. I haven't heard that one. So far, it works. Is there a downside to Durolon?
Not that I know of. If it works, then hey, whatever works, keep doing it. So if you've had an issue with Biosim or Fujisim or ReliX or GI or anything else, then by all means, yeah, do whatever works. That's really kind of my philosophy in life. But definitely on a cement. That's why I just say know your cement. Use any cement you want to. Just know it. Know how it behaves. And if you found that it behaves better for you than Biosim, then by all means do it. The goal of Biosim was I didn't want to pay any more money. I wanted it to be light cure. I wanted it to act like an RMGI. I wanted it to have a radial opacity to that would block some of my discolored substructure, have a pulp access or decalcified tooth and so forth. So all those different kind of demands and requirements is what NuSmile met. And then they beat the price of anything else that I was using cement-wise. So it's still cheaper than any other cement that I use. So because it works so well for me, and my debond is less than a fracture of a percentage, which in what we do is awesome. Knock on wood. I'll probably get 10 of them tomorrow now. But when a crown comes off, I'm very surprised if it's a debond. But you do have to follow the DFUs. So the IFUs or DFUs that Biosim comes with are very important. You've got to follow. They're not complicated, but they're important.
Okay. No other questions coming through at the moment. Giving it a few more minutes. Let's see. Okay. Oh, let's see what we got here. Okay, Dr. Hunt, Biosim versus Fujisim 2. What are your thoughts?
If I have a really cooperative patient, that's kind of if I ever do have an issue with Biosim, that's what I would start using again because I've used it before. Fujisim 2 is great. I just come back to it's not light curable. And that's where I really love a light curable cement, which is why I used ReliX for a little while. Because if I have a patient that's unconscious or in nitrous, like was asked a moment ago, and I've got D through G on there, or I've got multiple crowns and the patient's moving around, I have to wait for like 2 minutes for that to set up. And when it goes from not quite set to set, I just want to make sure I'm not messing up that bond, or more importantly, shifting my teeth. Where I had all these beautiful teeth straight in a line, now they're supposed to be your offset like they naturally were, and then they move at the last second, like a lot of times happens, unfortunately, with a normal natural set cement. You don't have the ability to light cure that. That's why I love the Biosim and even a curable. I think if you love the Fuji products, I actually think the Fujisim Evolve is a good option. That's a newer product by GC that is a light curable cement. It's a Fujisim Evolve LC of course for light cure. If you place that on there, it'll work very similar. It's got a couple of different nuances than Biosim. So again, read the IFUs so that you know what the issues are if you have them. But that would be my other choice because it gives you all the properties of an RMGI, but it is light curable. I think that light curable to have Zirconia is placed exactly where you want them every single time, which is my dream. Is, hey, I want to be able to get these canines in the right spot. I want all my front teeth to look like this kid just had ortho, or at least what they came in with. I've got to have a light curable cement, because 2 minutes is a long time to hold a crown while a kid is moving around and have them line up exactly where I want them. So anyhow, that would be my second choice, would be Fujisem Evolve. It does cure a little bit different. It is very strong, but just read the IFUs on that if you decide to go that direction.
Okay, let's see. Got a couple more. Really appreciate this lecture. Great job. Just curious. So really appreciate this lecture. Great job. Just curious, what are your thoughts on Zirconia versus Bioflex? What would you recommend for an amateur jumping in more aesthetic posterior restoration?
Well, jumping in, the Bioflex is going to be a lot more user friendly. That's for sure. The aesthetics of the Zirconia are just going to be better. So if I'm looking to do some ease, like if I'm doing AJKNT, and that's what I'm dealing with, then a Bioflex is going to be much more user friendly. It's going to do much more like a stainless steel crown type of preparation. If I'm doing BILNS right in the smile line, and I know the parents' aesthetics are going to be very important, and I'm going to be charging them a handsome fee, then I'm going to use Zirconia on those. So the Bioflex it's better than a 5-surface or a 4-surface or even a 3-surface composite, but it's not Zirconia. So it's not going to give the aesthetics. It's not going to have that nice glass look of reflectivity, and it's going to look like a natural tooth that came out of a lab. So if that's what you're looking for, you definitely want to learn how to do the Zirconia, and definitely in the smile line. But that would be, they are two different preparations. So aesthetic wise, I would go with the Zirconia for sure. Ease of use and non-aesthetic, better than a 4-surface composite. If that's what you're up against on an E, then the Bioflex is going to be a better choice. Bioflex fills a purpose, but it doesn't replace Zirconia, definitely in the aesthetic world. But it's better than a giant composite.
Okay, thank you. Dr. Johnson, there was a comment in a slide about fitting a smaller crown before cementing the final crown. Can you elaborate on that?
I wouldn't do that. I might have to get a little more feedback from you on that. So I probably either misspoke or misread, but the goal on that is giving the patient the size that they came in with. That's always my goal. If they have size 2 front teeth and size 2 centrals and size 3 laterals, that's really what I want to do. But if it doesn't look right, or if I'm only doing 1 or 2 of them, that's when I'll size down. Is if I try a size 2 and it's like, man, this kid really is a size 2 there, or whatever it is, 11.2 millimeters. And then I put that triangle crown on, like, man, that just looks big. Then I'm going to size down. If I feel like it's borderline, or if I'm only doing a single tooth, then sizing down tends to work out a lot better. So if I have to choose between a 3 and a 2, because I'm not sure, I always go with the smaller size. But I definitely, outside of that, I probably either misspoke or misread, but I definitely wouldn't want to mix up those two. My goal is to figure out what size I'm going to use from the beginning, and then not touch any other crowns, and put those all aside, so I'm not fumbling through a bunch of wet, bloody crowns. So I might have misspoke on that, but that would hopefully that clarifies how I would do that.
I hope that answers that. Okay. Got a few more coming in. Let's see here. Any tips on how to extract teeth with Zirconia crowns without shattering them?
Yeah. I did some this morning. I took out actually 4 of them that were all double row lower anteriors that I had done several years ago. On those with the single rooted ones, what I tend to do is, most of you probably grab that with a forceps and then you just rotate it. Typically, if it doesn't have a crown, you just grab a single rooted and you just rotate it and it slides right out. If it has a Zirconia crown on that, then what I'll do is I'll grab it and I'll rock it a little bit, buccal and lingual, and then I slide it up and out. I just want to break that PDL going buccal to lingual instead of doing a rotation, because for whatever reason, when I rotate it and pull in my normal enamel/dentin extraction tooth, it slides right out. But on a Zirconia, I just give it a little bit of a rock first and then take it out. Same thing with buccal and lingual on the posterior. I just am a little bit slower and easier on that tooth before I come right out. But at the end of the day, especially if you've got a conscious patient, it's not going to be unusual for that tooth to break, and just be ready to get the pieces.
Okay, great, thank you. Would you recommend anterior zirconia crowns if there is any crowding, Dr. Gomez?
I don't not do it with crowding. I just want to make sure that I either give them exactly what they already had. Lower anterior crowding, if we're talking edge to edge, then I just want to match what they already have. But if we have overlap teeth where they're all on top of one another, I would rather do a larger composite and then even kind of open those up. I have done that where they came in and maybe the natural tooth was like a size 2 central and a size 3 lateral. In that case, I'll just size down one more and do that. The tricky thing is most of the crowding happens in the lower anterior, and that's also where you've got the most limited amount of real estate from the dentin to the nerve. And so you've got to be very careful that you're likely going to have to do some kind of pulp therapy on those in the first place. And so you run out of tooth structure pretty fast. If they're just edge to edge or maybe 10% crowding, then I think using the tooth they came in with or one size smaller works out great. And I've done that a lot of times. If they're overlapping and on top of one another, then either doing a composite or taking those out might be the right plan. There's not always a zirconia for everything, but doing that or using a different tooth, that'd be fine too. Meaning that I'll use, even this last week, I had a case where we just did tooth number E, and the central just didn't look right because it was a long and narrow tooth. And so I used a lateral for the central, and then just did a little bit of a light manicure on the zirconia itself to make it look like a central.
Okay, thank you, sir. Next question, Dr. Allura, if I said that right. If insurance covers these crowns at a very low fee, will you charge the difference or not bill insurance at all?
Well, that becomes a challenging insurance question. If you take an insurance and if you're a network and they cover that procedure, then you either have to do the procedure or not offer the procedure. So you have to do it at their cost, and not bill the difference.
Okay.
So unless you have something, an email from someone that says you can, you just have to take their fee.
Next question, are the preparation techniques between posterior primary and permanent zirconia crowns the same?
Yeah, I don't do a lot of the permanent zirconia crowns because I'm very careful that I don't want to mess up the future of that permanent tooth. I'm very mindful of those things, and so I've done them. I'm not opposed to doing them. The answer is yes. The preparation is the same because the thickness of the crown is almost identical. So the preparation is the same. I just want to make sure I don't take away future options. And so, like most of you, I see a lot of hypoplastic teeth. I see a lot of poorly formed molars from whatever trend it is that we've got all these molar incisor hypoplasia cases and 6s that are bombed out and compromised. I see a lot of those as well. I would rather do a composite. I would rather do a stainless steel crown. That's my favorite, is doing a permanent stainless steel crown. That's very conservative. That's my just short of a Hall crown, where I just do a break contact mesial distal, do a light occlusal reduction, and I really want to save that tooth for a general dentist 18 years later for them to make a beautiful permanent tooth, or 10 years later whenever they can get a permanent crown. I've done them. I'm not against them. Dr. Bond has a really good lecture on those that New Smile has some things on. He's one that could speak that a lot better, but I kind of shy away from some of that and prefer to do a stainless steel crown. Dr. Johnson really likes to do a band. She does a molar band that fits really well, and then does a large composite, and then hands it off to the general dentist that way. So those are kind of the different options. As far as zirconia on permanent molars, not my forte, and not something I love, because I do feel like I might take some options away from a nice lab fit on a general dentist someday.
Okay. Dr. Tolian, pseudo class 3 cases with anteriors, do you open versus do to help retention of anteriors?
You could. My goal would be just to leave everything as it was, because if they've got a functional pseudo class 3 when they come in last week, if they didn't have any cavities, that's what they would have next week. And so if they come in with that, I like to leave them with that. For that reason, I really don't like to cross the midline. And so if I'm doing C through H or D through G, then I will do the left side first, and I will just match the contours of the right side. and then I will flip and do the other side, and I'll take the right, and now I match the left. So I really, really try to stay in that box. I don't love going outside of those things. Opening VDO, as long as it's minor, I think is fine. It's just tough to get that symmetrically, and to do that really well. Definitely if you have any posterior restorations. And so opening the posterior bite, understanding what that's going to do to the anterior bite with a standstill crown, I think can work. But I really just want to give them whatever they already came in with. Otherwise, it becomes Dave Evans' problem, and I've already got enough problems. So I really just try to leave things as they were. But it's not a bad thought. It's not a bad thing to do. You just got to be able to do a follow up and a recall, understanding that patient might need some occlusal adjustment or a crown replaced and adjusted, later at a later date, whether that's awake or asleep.
Thanks, sir. Next question. And I have probably a few more minutes left, a few more questions that can come in, but this next question, what's your take on sprig crowns versus zirconia preparation technique? I guess that's maybe NuSmile zirconia preparation technique. What's the difference? Need me to read it one more time? Okay.
No, that's fine. Okay. I mean, the question is zirconia versus NuSmile versus zirconia on the preparation. I actually have a lot of respect for Sprig. I like them. They've done good things for kids. They've done good things for the market. I have a lot of friends that use Sprig, and so I have nothing wrong with that. I will say that because of the shape of their crown, their preparation is a little bit easier to do because it does have a little bit more of a divergent gingival profile. You don't have to worry as much about that. For that reason, you're going to put a little more pressure in the sulcus. You're going to potentially blanch some tissue. I don't think that's causing like major issues. I don't think that's something people should be embarrassed or worried about. But the preparation, I think, is a little more forgiving on a Sprig crown because of that divergence. But I think the aesthetics and the emergence profile of a natural tooth on the NuSmile crown is probably a little more accurate. So I think they both have some trade-offs. But again, it's not a negative thing. They're just a little bit different.
Okay. Let's see. Time for a few more questions if there's any left. Let's see. Okay.
That'd be the best timed webinar we've ever done, or anyone's ever done. We're right on time with everything.
Yeah, no. Looks like we got one more. Or well, let's see. I wanted to make sure I heard correctly that if you see the crown slightly bulky, you have reduced the surface of the crown. Make sure. I wanted to make sure I heard correctly that if you see the crown slightly bulky, you have reduced the surface of the crown.
I don't think I understand that. Are we asking if we can reduce the surface of a zirconia crown, like a facial or a lingual?
Yeah, let me see. We'll come back to it. If you can, have some anonymous, if you can elaborate a little bit on your question, maybe we can catch it towards the end.
Yeah, the goal on those is you just want to be in the same facial profile. So you just have to be within. My goal is I don't want it to stick outside of the arch form. And so if the facial profile of the patient, I want to drop that a little bit lingual. So in that case, you usually take off a little more of the facial because that's where you're going to get your first resistance. And so in that case, I might prep a little more facial, a little less lingual. I just really want to be in the arch form. If anything sticks outside of the arch form, it does make it look like something is off, even though you did everything else right. The crown size is right. Your pulp is beautiful. If we're not within the arch form on an anterior tooth, it does just reflect light different. It just doesn't look awesome.
Okay. Good. It's the last question I will be able to take for this evening, but the last question I have is, what do you do when you do not have enough interocclusal space in posterior teeth?
Well, if you didn't have enough interocclusal space, that would mean you've got either some severe bruxism going on, an occlusal wear, and you're probably looking at the dentin. That would be about the only reason I can think of that you would lose like a VDO or a posterior interocclusal space. And so if you don't have enough space there, you might just need to do a stainless steel crown. Definitely if you're doing a patient that has severe bruxism and you can see the dentin on all these teeth along with the caries, then I would just tell those parents we need to do a stainless steel crown on those, and we're probably going to be replacing those every 18 to 24 months because he's going to grind right through these too. So a severe bruxism, which I should have mentioned somewhere along the way, I don't love doing zirconia crowns on those. If I have a parent that's going to be devastated without them, In that case, then I will do the E's in stainless steel crown, and I will cut the D's a little bit short, and just seat them a little more subgingival, so the pressure is on the E's and I've got the aesthetics on the D's.